So let's start the chapter pelvis. So we're starting the chapter pelvis with our perineum. Okay. So if the patient is lying in the lithotomy position you know from the general anatomy. Okay. Then your pubic symphysis here, and these are your ischial tuberosities, body of pubis. Okay, and pubic symphysis between them, and this pubic arch is there, and this triangle which is formed, is called as a urogenital triangle, and this triangle which is formed, this one is your anal triangle. Okay, so urogenital triangle, anal triangle, you can see the formation here. So talking about, you can make this diagram in your exam if perineum is asked. There's a pubic symphysis. Okay, these are your pubic bones. This is ischiopubic ramus, which is forming the boundaries of your urogenital triangle, and your anal triangle is present below the urogenital triangle, bounded by your coccyx, and your sarcotuberous ligament connects the ischial tuberosity to the body of the sacrum. Okay, this is a sarcotuberous ligament, and this is the anal triangle. Okay, so urogenital triangle, anal triangle, this you understood. About the pelvic diaphragm, in the pelvic diaphragm, three muscles are mainly there, like a pubococcygeus, iliococcygeus, and a ischiococcygeus. That is also called as a coccygeus, and this pubococcygeus and iliococcygeus together are called as a levator ani. Okay, which can elevate the anus. Okay, so pubococcygeus and iliococcygeus, these two muscles are elevating the anus, so it is called as a levator ani. And this muscle is ischiococcygeus, also known as coccygeus. Okay, and you have the urethral opening here, the vaginal opening here, and the rectal opening here. So you have a pubourethralis, pubovaginalis, okay, and a puborectalis. This puborectalis is called as a muscle of continence. Understood? And this all three muscles, this pubourethralis, pubovaginalis, and puborectalis, these are the modifications of your pubococcygeus. Okay, these are modifications of your pubococcygeus muscle. So this pubococcygeus is modified into pubourethralis, pubovaginalis, and the puborectalis. Understood? And this pubococcygeal and iliococcygeus and your ischiococcygeus form the pelvic diaphragm. Okay, so pelvic diaphragm is bounded on the superior surface by the pelvic fascia. Okay, and the inferior surface by the anal fascia. Okay, and these muscles are forming the pelvic diaphragm. So talking about this, let's say this is a pelvic diaphragm. Okay, pelvic diaphragm. So we have a muscle which is up in the upper position of your pelvic diaphragm. Okay, superior to your pelvic diaphragm is a piriformis muscle. Okay, and the pudendal nerves and vessels, like you can imagine, this is your greater sciatic notch and lesser sciatic notch. Okay, this is a lesser sciatic foramen. Okay, as you're seeing the lithotomy position, don't get confused of this section. What is that? The leg must be like this. Okay, so lithotomy position, this is a lesser sciatic notch and the greater sciatic notch here. Okay, sorry, here greater sciatic notch and the lesser sciatic notch here. Okay, so talking about this, you have a piriformis and the internal pudendal nerves and internal pudendal vessels, the pin structures which are passing from the lesser sciatic notch towards the greater sciatic notch. These are there. And talking about ligaments, you have a sarcotuberous ligament here and a sarcospinous ligament like this. Okay, so this is another diagram which is showing another muscles of the perineum. Okay, so this is the inferior layer of the urogenital diaphragm. We told it's a perineal membrane. Inferior layer of urogenital diaphragm is called as a perineal membrane. Okay, so perineal membrane. Talking about this inferior layer of urogenital diaphragm, we have three muscles. Like here we have the ischiocavernosus, we have the bulbospongiosus, and your in this side of your ischiocavernosus. Okay, so two ischiocavernosus muscles are there and one bulbospongiosus muscle is there, and this is called as a perineal body, green structure. It is called as a perineal body. It's a major support for the pelvic viscera, and this is your external anal sphincter which is guarding the anus. So you can consider this as the anus, and this is the external anal sphincter that is guarding the anus. It is voluntary. External anal sphincter is voluntary, but your internal anal sphincter, okay, it is involuntary. Talking about this, we have two other muscles in present transversely here, which are called as superficial transverse perineal muscles. Okay, so talking about this, the pelvic floor is formed by pelvic diaphragm. Pelvic floor is formed by pelvic diaphragm, which is comprised of your levator ani, puborectalis, pubococcygis, and the iliacoccygis. You can see here all three muscles. This muscle is the puborectalis. Okay, then you have your pubococcygis and your iliacoccygis muscle here. Okay, and your coccygis, that is your ischiococcygis, is present here. Okay, so this is a pelvic diaphragm, and we have the urethral opening, the vaginal opening, and the rectal opening here. And the modifications of your pubococcygis, these are guarding your puborectalis, pubovaginalis, and pubourethralis. Okay, this muscle, your pubourethralis, pubovaginalis, puborectalis. Understood? So this you can understand the diagram. Okay, and what is perineal body? Perineal body is a fibromuscular node formed by interlacing of 10 muscles. Okay, it is a fibromuscular node which is comprising of about 10 muscles. Okay, so what are the 10 muscles? We will see about this diagram. This diagram is also showing a levator ani muscle from the inferior view. Okay, so you can just see your ischial tuberosity it is there, your sarcotuberous ligament which is going it is attaching to the ischial tuberosity. Okay, and your your levator ani muscle is present over here. Okay, you have your your pubococcygis here, which is a part of the rami. Okay, so ischiococcygis here, it's a part of your levator ani. Okay, and this pubococcygis is later forming on this all three muscles. Okay, pubococcygis, that is forming this muscles. Understood? It's yet another diagram, and it's yet another diagram which is showing the muscles like your urogenital diaphragm we saw. So we have your urogenital triangle. So in urogenital triangle, what muscles are there? Your bulbospongiosus, which is present in the bulb, which is making the bulb of the penis. Okay, and your urogenital triangle. Okay, it is bound by two other muscles, that is your crus, that is formed by your ischiocavernosus. Crus is formed by your ischiocavernosus. Okay, and you have the pudendal canal here. Pudendal canal must be lying somewhere like this, and the perineal body is here. Perineal body is present just below your bulbospongiosus. Okay, and talking about your perineal membrane, this is the perineal membrane. This is a perineal membrane. Okay, and superior to the superficial to the perineal membrane is your muscles present. Okay, and if this is the perineal membrane, we talked about the perineal membrane also. Okay, so this whole part is the yellow part is the perineal membrane, which is the muscles are lying just superficial to the perineal membrane. Okay, understood? So this is the section. After that, talking about your levator ani or pelvic diaphragm. Okay, levator ani is present in the pelvic diaphragm. We talked about the pelvic diaphragm also. Pelvic diaphragm. Okay, so this levator ani was present. Levator ani comprises of which muscles? Your pubococcygis and your iliacoccygis. Okay, these are present in your, and these are called together as a levator ani. Okay, so this is a pelvic diaphragm, and pelvic diaphragm in the front, the superior part is formed with pelvic fascia, covered with pelvic fascia, and in the inferior part your anal fascia. Perineal body is the interlacing of 10 muscles. What are the 10 muscles? 4 paired muscles, 2 unpaired muscles. So what are the 4 paired muscles? The superficial transverse perineal muscle we saw here. Superficial transverse perineal muscle we saw here. Superficial transverse perineal muscle is there. Okay, and your deep transverse perineal muscle, which will be deep to this. Okay, and your bulbospongiosus you saw, and your levator ani also. This levator ani. Okay, these both muscles are also contributing to your perineal body. Okay, and of 2 unpaired muscles like your external anal sphincter and your longitudinal muscles of rectum. External anal sphincter we saw in the diagram, and we have the longitudinal muscles of rectum also, if it is present, or I have drawn. Okay, there is we haven't drawn because it won't be visible here. Okay, in this section probably. So longitudinal muscles of rectum is not visible, so you can remember this 2 unpaired muscles: external anal sphincter, longitudinal muscles of rectum, and 4 paired muscle, that is superficial transverse perineal, deep transverse perineal, bulbospongiosus, and a levator ani. Okay, talking about the sagittal section, if we take a sagittal section, so here will be your pelvic diaphragm will be present over here. Okay, and in that inferior part, that in the lower part will be bounded by the anal fascia. Okay, so this is a pelvic diaphragm. It will be bounded by the pelvic fascia, and anal fascia will be bounded in the lower part. Okay, so talking about this, we have the anterior abdominal wall going up like this, anterior abdominal wall going like this. Okay, and if you see here, you have a transverse perineal ligament which is going into the plane of the paper. Okay, and this is a superficial layer of your urogenital diaphragm, and the deep layer of the in the inferior layer. This red one is the inferior layer of your urogenital diaphragm. Okay, and the superficial layer of urogenital diaphragm, the inferior layer, the superior layer of urogenital diaphragm, the inferior layer of urogenital diaphragm. This is majorly forming a DPP. What is DPP? Or deep perineal pouch. A deep perineal pouch. So the roof of the deep perineal pouch is the superior layer of urogenital diaphragm. Okay, and but according to the new concept, it is open. It is open. Okay, there is no such thing as a superior layer of UGD. Okay, according to the new concept. And the floor is formed by the perineal membrane. Floor is formed by the perineal membrane. You can see. Okay, the perineal membrane must be forming its floor. Okay, and what is the anterior relation? So anterior is, you have the transverse perineal ligament. You can see the transverse perineal ligament here. Okay, and posteriorly the fusion of superior and inferior layer of UGD. Okay, this two layers are fusing. Okay, so you can easily write the boundaries of DPP. Okay, and if there is an injury to the membranous urethra, we'll talk about the urethra in a while. So just remember, if there is injury to membranous urethra, urine accumulation take place in the DPP, the deep perineal pouch, and also in the pelvis. Okay. Talking about the superficial perineal membrane. Okay, like this is a superficial perineal your perineal pouch. Sorry, superficial perineal pouch. So this is a superficial perineal pouch bounded in the anterior part. Okay, bounded superiorly by your inferior layer of deep UGD. Okay, so roof is formed by a perineal membrane. The inferior roof is again formed by the perineal membrane. Okay, talking about the perineal membrane, it will form its roof. Okay, the roof will be formed by the perineal membrane, and the floor will be by the Colles fascia. Just look, this is the Colles fascia. Okay, so if you are getting confused how the perineal membrane will be present, so perineal membrane will be present like this somewhat. Okay, and the floor is formed by the Colles fascia. Okay, Colles fascia, this anterior abdominal wall, okay, goes like this and forms in the scrotal area your dartos muscle. Okay, dartos muscle, and again the Colles fascia, which will fuse to the inferior layer of UGD, urogenital diaphragm. So boundaries, what are the boundaries of a superior perineal pouch? So roof is formed by perineal membrane, floor by the Colles fascia. Posterior wall is a fusion of perineal membrane and the Colles fascia, fusion of your perineal membrane and the Colles fascia. Okay, and lateral wall is the ischiopubic ramus. You can see your ischiopubic ramus in this diagram. Okay, ischiopubic ramus, and anterior wall is open. Okay, so anterior wall, this is the anterior part. Okay, it is open, and you can see the penis here. Okay, and here you can see the urethra that is going on. Okay, and then it is opening in the glands. Okay, so this is the transverse section, the sagittal section, showing a deep perineal pouch and a superficial perineal pouch. So if there is injury to spongy urethra, you can just look at this point. If there is injury to the membranous urethra, at this point the membranous urethra is passing through the deep perineal pouch. If there is injury to the membranous urethra, the urine will tend to accumulate here. But if there is injury to this part, okay, to the spongy urethra, this is called as a spongy urethra. Okay, so if there is injury here, the urine will accumulate in the superficial perineal pouch. The urine will tend to go here to the superficial perineal pouch. Okay, so if there is urine to the spongy urethra, okay, in the bulb of the penis, urine can accumulate in the superficial perineal pouch, or it can go into scrotum. Okay, and anterior abdominal line till the floor of axilla also. Okay, urine can be seen till the floor of axilla also, because it can run along the anterior abdominal line. Okay, and that opens into the axilla, and your upper part of thigh till the Holden's line, till the Holden's line. Okay, so urine accumulation, if there is injury here, it can move to the deep SPP or collect here. Okay, or it can move through the anterior abdominal wall, okay, to the axilla, to the floor of axilla also. What are the contents of the deep perineal pouch? So you have like made the deep perineal pouch in this manner, okay. So what we have our membranous urethra present, okay. Membranous urethra is present, which is guarded by external urethral sphincter. This external urethral sphincter will be guarding the membranous urethra, which is external urethral sphincter is called as the sphincter urethrae, okay. Then we have the bulbourethral gland must be present, which will be connecting to the membranous urethra, which is called as the Cowper's gland, only in males, okay. Cowper's gland is present only in males, okay. The analog of Cowper's gland is Bartholin's gland, present in the female, okay. So you have the bulbourethral gland or the Cowper's gland that is connecting to the membranous urethra, and your deep transverse perineal muscle. This is a deep transverse perineal muscle. We saw the deep transverse perineal muscle where in the perineal body. It is from the superficial transverse perineal muscle, which is visible here, superficial transverse perineal muscle, but the deep perineal muscle was not visible. So here you will see a section, okay, cut section of your deep transverse perineal muscle. And what are the structures that are piercing the perineal membrane, okay. They are also the contents of a deep perineal pouch. If you talk about the perineal membrane, okay, it's perineal membrane, yes, the inferior layer of the urogenital diaphragm, that is the perineal membrane. So structures which are crossing the perineal membrane, the structures which are passing through the perineal membrane will also be the contents, okay, will also be the contents of your deep perineal pouch. Contents of the superficial perineal pouch. So we have the structures below the perineal membrane, okay, structures that are present below the perineal membrane. So talking about this, we have the bulb and the bulbospongiosus muscle, okay, and the crus or ischiocavernosus, okay, and your superior transverse perineal muscle and the Bartholin's gland, that is your analog of Cowper gland in female, okay. Bartholin's gland is greater vestibular gland, okay. These are the structures below the perineal membrane. So if you're confusing in upper and below, okay, so just make a concept that the thing which is present more anteriorly is superficial, okay, and the thing which is present more posteriorly is must be a posterior part, like which is present like posteriorly, okay, that must be anterior part, okay, that will be present up, and the thing which is present more like superficially, okay, that will be the posterior part, okay. So you can get an orientation if you are imagining the lithotomy position, okay. I have no time to talk as it is a revision video. So we have this, and talking about other things, the structures piercing the perineal membrane will also contribute to your superficial perineal pouch, okay. What are the contents? Bulb and bulbospongiosus, the crus and ischiocavernosus, superficial transverse perineal muscle, and the Bartholin's gland, okay. So what are the structures that are piercing the perineal membrane? Okay, let's read about this. What are the structures that are piercing the perineal membrane? Here we wrote what are the structures piercing perineal membrane, structures piercing perineal membrane. So what are the structures? Okay, what are the structures? So talking about this, we have this perineal membrane, okay. Let's draw the perineal membrane, and what are the structures that are like piercing, okay. So you can see a transverse perineal membrane, you can see the transverse perineal membrane, okay. And what are the structures in the upper apex part? You have your deep dorsal vein of penis, okay, which is not the content of your perineal pouch, okay. It is not the content of the perineal pouch, okay. And your dorsal nerve of penis, okay, below the deep dorsal, two dorsal nerve of penis, which is the content of only deep perineal pouch, not of your superficial perineal pouch, okay. And then you have the dorsal artery of the penis in this part, and the dorsal deep artery of the penis in this part, in the lower part, a little bit lower part, okay. You have the urethral opening here, urethral opening is present over here, and urethral artery must be there just above your urethra, okay. And the artery to the bulb of penis is present in this part, and the ducts of your bulbourethral glands or your Cowper's glands are present in this part, okay. And also it is pierced by three structures, that is a nerve arterial vein and nerve arterial vein, the superior scrotal nerve arterial vein, the posterior scrotal nerve arterial vein, which are the contents of the deep perineal pouch, okay. Understood? And the duct of bulbourethral gland we told, okay. So talking about this, which are the contents of which perineal pouch, let's see, okay. So you have your pudendal canal here, you have a pudendal canal, okay. And this part, Yes, this part is the content of it. This is a deep perineal pouch, and this must the superficial perineal pouch that will be present over here. Okay, I haven't drawn. Let me draw. This is the opening of a superficial perineal pouch here. Okay, this is a SPP and this is a DPP. So talking about this, let's see how the structures are running. Okay, so we have the prostatic venous plexus, which is draining the lymph from the penis. Okay, that is a prostatic venous plexus. Okay, and this vein is called as a deep dorsal vein of penis. Okay, deep dorsal vein of penis. And we have a some structures like a pudendal canal is present just posterior to the deep perineal pouch. Okay, what are the structures of pudendal canal? You have the pudendal nerve, which is dividing into two branches, that is continuing as a dorsal nerve of penis. Okay, and it is going up to the glans. Okay, and another structure is a posterior scrotal nerve. Okay, this pudendal nerve also gives another branch, which is the posterior scrotal nerve. So this is the posterior scrotal nerve, which will run into the scrotum. Okay, and internal pudendal vessels are there, which are giving a branch which is called as your posterior scrotal artery. Okay, posterior scrotal artery and the posterior scrotal nerve. Okay, these are also going through the scrotum. Okay, so this structures, these all structures, posterior scrotal nerve and vessels, must be the content of DPP only. Okay, this is the contents of deep perineal pouch. These are not coming in the superficial perineal pouch. And the dorsal nerve of penis, this is also a content only of DPP. Okay, it is a content only of your deep perineal pouch. And this deep dorsal vein, it is not the content of perineal pouches. Okay, deep dorsal vein is just going like this. Deep dorsal vein is just going in this course. Okay, so it is not entering any of the pouches, and this is contributing to the prostatic venous plexus. So if we got an orientation of the perineum, let's move ahead. So let's now talk about the ischiorectal fossa or the ischioanal fossa. Okay, which is called as the ischiorectal fossa or the ischioanal fossa. Understood. So let's talk about this, and we have to read out the contents and all of this ischiorectal fossa. So if I want to show you that, these are your superficial perineal pouch and deep perineal pouch structures. Okay, and this diagram must be shown in the previous one. Okay, so this is your bulbospongiosus. Let me label the diagram. Okay, so this is your bulbospongiosus muscle. Okay, and this is ischiocavernosus, which was making the crux. Okay, and the superficial the transverse perineal muscle, superficial transverse perineal muscle. Okay, STPM, superficial transverse perineal muscle. And this is the body of the penis. Okay, and this is the glans. Know all this. And another thing which I want to tell you, that this one is your this muscle is a piriformis. This is a sarcotuberous ligament. Sarcotuberous ligament. This is a sarcotuberous ligament, and we have our puborectalis, which is guarding the rectal region. Okay, this is a puborectalis, which was guarding the rectum. Okay, guarding the rectum. This is a puborectalis. Okay, your external anal sphincter, this is a EAS, external anal sphincter. Okay, and your pubococcygeus, this part is a pubococcygeus. Okay, and this part is a iliococcygeus, and this is a iliococcygeus. Okay, so you can label all the muscles, you can know all these muscles. Okay, and this is also in the muscles of the superficial perineal pouch. Okay, talking about the ischioanal fossa or the ischiorectal fossa. So what is this? The anterior margin is the posterior margin of a perineal membrane. The posterior margin of the perineal membrane is the anterior margin of a ischioanal fossa. Okay, and laterally is bounded by your obturator internus and your obturator fascia, which is binding the obturator internus. Okay, then we have the things which are your medial part is your external anal sphincter and the levator ani, which are forming a medial part. Okay, and the posterior part is formed by a sarcotuberous ligament. This is a sarcotuberous ligament. Okay, you can write here, this is a sarcotuberous ligament. And which muscle? Your gluteus maximus muscle. And gluteus maximus muscle must be present like this, and this is forming your ischioanal fossa. Okay, and the base of the ischioanal fossa is formed with the skin of the gluteal region. Okay, so you can just imagine the base, what must be the base. Okay, and here the apex is formed by the fusion of your lateral and medial walls. Okay, the lateral wall and the medial wall, these are fusing to form your apex. So there is a horseshoe recess. Okay, the communication between both ischioanal fossa behind the anal canal is called as a horseshoe recess. Okay, talking about the horseshoe recess, this one is a horseshoe shaped recess, a horseshoe shaped space. Okay, horseshoe shaped space, which is like forming your ischioanal, which is communicating between the both ischioanal fossa behind the anal canal. Okay, so you have the two ischioanal fossa here, and this is forming your horseshoe like space, which is called as a horseshoe recess. And if you take a coronal section through the anal canal, coronal section, so talking about this, we have our anal canal here, okay, and the external anal sphincter, okay, and the levator muscle, that comprises of your iliococcygeus, okay, and the ischiococcygis, okay, so sorry, your pubococcygeus and your iliococcygeus muscle. Then you have the anal fascia. This is the anal fascia, which was covering the pelvic diaphragm from the below. It is the anal fascia. Okay, and your obturator internus muscle. This is the obturator fascia. Okay, this is your pudendal canal. Your obturator fascia, pudendal canal, and your lunate fascia is there like this. A lunate fascia, semilunar fascia type. This is the lunate fascia, and this is a perianal fascia. This is a perianal fascia, and external anal sphincter we know. Okay, so this whole part is a ischioanal canal. Okay, this yellow part, in fact. Okay, this is just coronal section through the anal canal. Okay, the anal canal. So what are the major contributors? Your lunate fascia, three fascias are there. Okay, which are your pudendal, that is obturator fascia, your lunate fascia, obturator fascia and the lunate fascia, and the fascia of the pudendal canal, that is binding. Okay, this is the obturator fascia, which is this part, and the lunate fascia is this part. So this obturator fascia is forming the major boundaries. Obturator fascia is major contributor. Okay, and this is called as the perianal fascia. Okay, three fascias: lunate fascia, obturator fascia, the perianal fascia. Okay, and you have the 1, 2 and 3 parts. 1, 2 and 3. This 1, 2 and 3 comprises of your ischioanal fossa. So we have a perianal space, your ischiorectal fossa proper, and the suprategmental space. So this one part is called as a perianal space. The space below the perianal fascia is called as the perianal space. Okay, 2 is the ischiorectal fossa proper. This is the proper ischiorectal fossa. Okay, and the third one is called as a suprategmental space, and here fat is loosely arranged. This third part is your ischiotegmental space. Okay, sorry, suprategmental space. Okay, and in the perianal space, you have a lot of connective tissue is present, so fat is tightly loculated. So injections of this space are extremely painful. Okay, if you give an injection in the perianal space, it is extremely painful because fat is like tightly loculated here. Okay, so we are piercing more of the fat. Okay, so fat is the main content of ischiorectal fossa. The ischiorectal fossa contains most of the fats. Okay, so this was about ischioanal fossa. Okay, and your ischioanal fossa, we talked about all your ischioanal fossa or your ischiorectal fossa. Don't get confused, the same thing is there. Ischioanal fossa and ischiorectal fossa are the same. Okay, and talking about this, we have completed our ischiorectal fossa. After that, now let's talk about your pudendal canal, which is also called as the Alcock's canal. Okay, Alcock's canal, which is your pudendal canal, made up of your obturator fascia and the lunate fascia. Okay, so obturator fascia and the lunate fascia, these are making your pudendal canal. So obturator fascia and the lunate fascia, this two parts. Okay, this obturator fascia and this is the lunate fascia. These both fascias are making a pudendal canal. You can see this both fascia are making a pudendal canal. Pudendal canal will be like this, present like this. Okay, so talking about the pudendal canal, what are the contents? The pudendal nerve will come. The root values are S2 to S4. Okay, from the sacral plexus. It comes from the segments S2 to S4. It comes here and it gives a perineal branch. Okay, it gives a perineal branch which continues. Okay, and gives two muscular branches, as well as the perineal branch gives another branch which is called as a posterior scrotal nerve or a labial nerve. Okay, which goes inside the superficial perineal pouch. Okay, and supplies the scrotum. Then we have your another that continues giving a perineal branch, and then it continues as the dorsal nerve of the penis or clitoris. Okay, this is the dorsal nerve of the penis or your clitoris, DNP. Okay, then what happens is that this whole part is a ischiorectal fossa. This part is a ischiorectal fossa here. Okay, and another branch of pudendal nerve before it divides is called as the inferior rectal nerve also. Okay, and this canal is called as a pudendal canal. This is a pudendal canal. So deep perineal pouch and superficial perineal pouch, you can just relate this diagram. So pudendal nerve has three components: a dorsal nerve of penis, an inferior rectal nerve, and a perineal branch, that is a posterior scrotal nerve, and muscular branches. Okay. So talking about this, how they lie. So let's talk about this. This is a pudendal canal. So there is a deep in that DNP, that is your dorsal nerve to the penis. Okay, this one, dorsal nerve to the penis. This is the DNP, and we have the two other nerves, that is posterior scrotal nerve, and the posterior scrotal vessels are also present. Okay, and the inferior rectal nerve and the inferior rectal artery along with it. Okay, it lies posterior scrotal nerve. Along with posterior scrotal nerve, we have the posterior scrotal vessels, and with inferior rectal nerve, we have the inferior rectal vessels. Okay, and this inferior rectal artery and this inferior rectal nerve is most vulnerable to injury in the ischiorectal fossa abscess. Okay, what are the contents of ischiorectal fossa? The main content, the main content is a fat. Okay, so amazingly, the main content of ischiorectal fossa, it is the fat. Okay, and just don't forget to write fat. Then the pudendal canal, ischiorectal fossa is containing a pudendal canal, so it contains all the contents of pudendal canal, the pudendal nerve, the internal pudendal vessels. These all your posterior scrotal nerve and vessels, and inferior rectal nerve and vessels. Okay, talking about recesses, what are the three recesses? Okay, we have a horseshoe recess, or anterior recess, and our posterior recess. Okay, three recesses are there. Anterior recess is present deep to the urogenital diaphragm, and posterior recess is present deep to a sarcotuberous ligament. Okay, and if anal fascia and obturator fascia fail to fuse at the apex, so it is, the condition is called the hiatus subsquable. Okay, the hiatus subsquable. Okay, this is a hiatus subsquable, and this is the rare site for internal hernia. Internal hernia may occur here. Okay, if the anal fascia and the obturator fascia is fail to fuse at the apex. Okay, at this part you can see, if this anal fascia and this obturator fascia, they fail to fuse. Okay, so it will cause your hiatus. It will leave a hiatus, and this hiatus is called as the hiatus of Squalby. Okay, hiatus of Squalby, and this is a rare site for your internal hernia also. Okay, so this completes the ischiorectal fossa. Let's move on to the next part. Let's talk about the kidney, very important organ. Okay, it is a retroperitoneal structure. You can get a long question on the kidney also, so note that. It is present between the T12 to L3 level. In males it is 150 gram, in females it is 135 gram in weight. What the dimensions? 11 cm in length, 6 cm in breadth. The thickness is 3 cm. Okay, and what is the Morris parallelogram? So kidney is present inside this parallelogram like structure, which is called as the Morris parallelogram. Okay, so you have the dimensions here. So this is a T11 level, and this is a L3 level. Okay, this is a T11 and this is L3. So the kidney, one of the kidney is lying up, that is our left kidney will lie up. Okay, this left kidney will lie a bit up than the right kidney. So this is your right kidney. Okay, right RK, and this is the left kidney. So left kidney lies a bit up than your right kidney, and it touches the T11 level of T11 level also, and this right kidney starts from the T12 level. Okay, so you can write the levels at T12 to L3 only. Okay, so this is a right kidney like this, and this is a left kidney present like this. Okay, and this length is 2.5 cm, this length is 2.5 cm. Okay, so it is present just 2.5 cm distance from the this line connecting a T11 to L3. Okay, and this left kidney is about 5 cm from this part. Okay, so this length is 2.5 cm. Okay, again, and this whole part also, it is your 7.5 cm. This whole part is a 7.5 cm. Accordingly, this whole part will be 7.5 cm, and this box, okay, this box will be about 9 cm. So this is a Morris parallelogram. Okay, which encompasses the kidney. So kidney has two poles, that is the upper pole and lower pole, two surfaces, anterior and posterior, two borders, medial and lateral, and a hilum. Okay, so poles, upper pole is thick and rounded, and suprarenal gland is present. You must have observed the kidney is there, and suprarenal gland is present in its upper pole. Okay, this is its upper pole. So suprarenal gland is present, and the upper pole is a bit thick and rounded, while the lower pole is a bit thin and edgy, Hilar relations, anterior to posterior, what are present in the hilum. So you can see, and from anterior to posterior, this is the anterior part, this is the posterior part. So in the hilum we have the renal vein first, renal artery, and then renal pelvis. Okay, BAP, you can remember BAP. Okay, from anterior posterior we have a BAP structures, renal vein, renal artery, and the renal pelvis. Note that a branch of renal artery, that is called as a subsidiary branch of renal artery, if it is present, it is lying deep to the renal pelvis and is going even more posteriorly. Okay, talking about the relations of left and right kidney, so let's talk about the anterior relations. Okay, in just you have a trick to remember, like just think what are the structures present in the right, in the right part. Okay, so you have the liver, you have the the second part of duodenum must be present. Okay, and the hepatic flexure of colon, your jejunum. Okay, jejunum is present both in right and left, and your hepatic flexure of colon will be present like this. Like you just imagine your liver is like that. Okay, liver is like that, and that hepatic flexure of the colon will be like running like that. Okay, then the duodenum is there. Okay, and this is then attaching to the that colon part. Okay, so these are your structures. This right lobe of liver is leaving a hepatic impression, so liver is one of the anterior relation. Then the second part of duodenum in this part. Okay, and hepatic flexure of colon and the jejunum. Okay, and the left part, in the left part you have your suprarenal glands are present both in right and left kidneys. Okay, in the left you have your stomach is present. Okay, so your stomach must be lying like this. Okay, and it is leaving out a gastric impression, and a spleen is present just beside the stomach, that is your spleen, that is your splenic impression. Okay, that is your splenic impression. So spleen must be present like this, and your pancreas, for the impression for the pancreas is that there must be pancreas. Okay, which is present, impression for pancreas. And the splenic flexure of colon, the colon, like the colon just goes like this. Okay, just goes like this. This turn is called as a hepatic flexure, and this part is called as a splenic flexure. This is the splenic flexure of the colon. Okay, and the jejunum, obviously. These are the anterior relations of the left and the right kidney. Okay, and here in the posterior relation you have some nerves like a subcostal nerve. Okay, your iliohypoglossal, iliohypogastric, and your ilioinguinal nerve. Okay, iliohypogastric and the ilioinguinal nerve, and the lateral cutaneous nerve of thigh also. Okay, which will be forming the posterior boundary of your posterior relations of your right kidney. Okay, so talking about the right kidney, let's discuss the posterior relation. Okay, so let's say this is a right kidney. So talking about if this is a right kidney, so seeing the right kidney from the posterior view. So first of all you will have your arcuate ligaments, medial arcuate ligament and the lateral arcuate ligament, that will be present over here, medial arcuate and lateral arcuate ligament. Okay, and then we will have your impression for your 12th rib is present in the left kidney. Both 11th and 12th ribs are present. Why? Because the left kidney lies a bit up. Okay, the left kidney lies a bit up, so it will have your both 11th and your 12th rib present. Your diaphragm is related to this part. Okay, and the ligaments of diaphragm, that is the medial arcuate and lateral arcuate. Okay, and from this your subcostal vein, artery and nerves are arising. You remember from the diaphragm, this vessels are arising, the subcostal vein, artery and the nerves. Okay, and you have the muscle, that is the transverse abdominis. You have another muscle. Okay, that is a psoas major. The psoas major must be present here, and the quadratus lumborum must be present here. So you can see in this diagram also, and this is your lateral arcuate ligament, this is a medial arcuate ligament, which are forming the boundaries. Okay, and what are the muscles that are present? Your psoas major, and this psoas major muscle is this muscle. Okay, this muscle which will be forming a relation of your posterior relation of a kidney. Okay, and then you have the iliohypogastric nerve and the ilioinguinal nerve, which are also forming relation. This is the iliohypogastric nerve, this is the ilioinguinal nerve. Okay, and the psoas major, quadratus lumborum and the transverse abdominis, these three muscles are forming the posterior relations of the kidney. Talking about the coverings of the kidney, what are the coverings of the kidney? What are the things that are covering the kidney? So if we have the transverse section of the kidney is like if this was your kidney, you have just made a transverse section like that and you are seeing it. Okay, so first of all you have a fibrous capsule, that is a true capsule of the kidney. Okay, the fibrous capsule. and then you have some perinephric fat. Just look at the yellow structure, the perinephric fat. Okay, and third one is the renal fascia, which is called as the fascia of Gerota. Fascia of Gerota is the renal fascia, which is the false capsule of the kidney. And then you have the paranephric fat, okay, which is present more at the lower pole, okay, rather than your higher pole. So these are the kidney layers. Okay, you can well appreciate this. This is the renal fascia that is covering. Renal fascia that is covering. Okay, this is the most, the outer layer, the false capsule. Okay, then you have the perianal fat, so perirenal fat that is present just deep to your renal fascia. Okay, and then the renal capsule, you can see the blue part, you can see the renal capsule, and the kidney is there in yellow. Okay, and the pararenal fat is present outside. Pararenal fat is present outside. This pararenal fat is also called as a paranephric fat. Okay, let's talk about the sagittal section. The sagittal section of the kidney. Okay, sagittal section of the kidney, and we'll talk about a transverse section of the kidney too. Okay, so there are two other centers that we'll talk about, and then the blood supply of kidney. Okay, and the anterior surface, about we'll discuss about the renal artery and Brodell's line, nerve supply, renal damage, then this lymphatic drainage, and about some clinicals. So let's talk about the surface, that is your the transverse section is done. Your sagittal section, let's discuss the sagittal section. So you have the diaphragm here. Okay, and this that diaphragm from which the fascia of Gerota arises. This fascia of Gerota, this will cover this whole part, the suprarenal gland. Okay, and will also come down and cover the kidney. So this fascia of Gerota, this covers the whole kidney and the suprarenal gland. Okay, so the anterior layer of fascia of Gerota, which is called as the fascia of Told, and the posterior layer of your fascia of Gerota, which is called as your fascia of Jucker. Then you have the perinephric fat that is present inside. Okay, and the direction of perinephric effusion. Okay, if there is some perinephric effusion and fluid is accumulated, it will travel in this direction. Okay, and this just remember that the posterior layer, this merges with the fascia iliaca. Okay, and this anterior layer continues with the extraperitoneal connective tissue. Okay, so that is the direction of perinephric effusion. This direction is there. Okay, so this is a simple sagittal section. Talk on the floating kidney. What is floating kidney? Due to very less perinephric fat, the kidney is mobile within the layers. This fat is very less, so kidney can move. Okay, so it is called as a floating kidney. Okay, talking about the transverse section. Transverse section, the kidney shape will look like this. Okay, so what are the things that are forming a transverse section? So first of all, you will have let's get an orientation here. So you have a vertebrae here. You have the vertebrae, the transverse process, and all of your vertebrae. Okay, and this anterior layer of your that fascia that is covering the kidney, that is your fascia of Gerota. This anterior layer of the fascia of Gerota. Okay, this anterior layer of the fascia of Gerota, it is called the fascia of Told. So this is the fascia of the Told. This is the anterior part, and we are looking the posterior part from here. Okay, so this is the fascia of the Told, and this posterior layer is called the fascia of the Jucker. This is the fascia of the Jucker, which is connecting it to the vertebrae. Okay, and then you have the blood vessels which are piercing. The connective tissue septum is there, and the blood vessels are piercing the connective tissue septum to reach the kidney. Okay, so perinephric effusion, this from the kidney, this perinephric effusion it goes down rather than it doesn't travel medially. Okay, why it doesn't travel medially? Because the connective tissue septum is present, which is restricting the movement of your perinephric effusion. Okay, so this is a quadratus lumborum, and this muscle is a psoas major muscle. Okay, and the psoas major is covered by its fascia, and quadratus lumborum covered by this fascia. So thoracolumbar fascia is covering your quadratus lumborum. Okay, internal structure, you have the major calyces and the minor calyces. Okay, you know about the renal artery, the hilus, from which the renal artery and vein come out or go in. Okay, then we have this kidney. We have the cortex and the medulla of the kidney. This some extensions of the cortex that reach up to the medulla. These extensions are called as the renal columns of Bertini. Okay, this is also called as the renal column of Bertini. Okay, and we have a renal pyramids also in the medulla part. Okay, we have renal pyramids. These are of medulla. and from which this medulla is continued. This is the medulla of the kidney. Okay, this one. Inside this is the medulla, and the cortex, the extension of cortex in the medulla is called as your renal columns of Bertini. Okay. Blood supply to kidney is from abdominal aorta. Abdominal aorta, it comes by the renal artery, then divides into segmental arteries, 5 in number. Okay, segmental arteries. So this you can see segmental arteries are given somewhere. Yes, the segmental artery. So this is segmental artery which divides into 5 branches, 1, 2, 3, 4, and 5. Okay, this is the segmental artery which divides. The segmental artery will give you lobar artery. This lobar artery will give interlobal artery, will give arcuate arteries. Arcuate artery will give interlobular artery, again interlobular artery. This is not lobar, this is lobular artery. Okay, one to the each lobule. Okay, which will divide into afferent arterioles, reach the glomerulus, and form the efferent arteriole. So this from up to interlobal artery, this was in macroscopic level. From this afferent arteriole, this goes in the microscopic level, that is about your neurons, and that's sorry, nephrons. So afferent arteriole, from the afferent arteriole glomerulus, you know the structure of the nephron. Okay, this is a glomerulus, and some afferent artery is coming there, efferent artery is going here. Okay, and this your proximal convoluted tubule is there, loop of Henle, and the distal convoluted tubule, and goes back to the collecting duct. Okay, this is the structure of your nephron. So we have a afferent arteriole, then glomerulus, your efferent arteriole, and then reaching the glomerulus, the efferent arteriole. This divides into peritubular, capillaries, and the vasa recta. Okay, and this from this vasa recta, from this capillaries, the interlobular vein is formed, which form an arcuate vein, which form an interlobar vein, lobar vein, segmental vein, renal vein, which drain to inferior vena cava. Very simple. Arteries, and here the veins. These are just more or less same. Okay, and the capillary network is the peritubular capillaries and the vasa recta. Okay, so you can just look at the things here which are given. I have discussed all this, and take a screenshot if you want. Okay, this renal artery, it has an anterior division and a posterior division. Posterior division has 4 segmental arteries. So anterior division is 4 segmental arteries. Posterior division is only 1 segmental artery. So talking about the anterior surface of the left kidney, so this is the anterior surface of the left kidney. Okay, so this anterior division, this divides into 4 branches, and the posterior division has only 1 branch. Okay, so it has only 1 segmental artery. So first is the apical segment, the superior segment. Okay, the anterior superior segment, that is the upper segment, the anterior inferior segment, and the inferior segment. Okay, there are 4 branches. If we flip, it will just look like this. Your anterior division that is going posteriorly, the anterior division that is like going posterior to this diagram. Okay, and this posterior segment, this is a posterior segment of the kidney. Okay, which is supplied by the posterior division of a renal artery. Okay, and here a line is present which is called as a Brodell's line. This Brodell's line is present on the posterior surface at the junction of medial 2/3 and the lateral 1/3 of kidney. So medial 2/3 and lateral 1/3, this junction, the Brodell's line is present. It is a functional avascular plane. It is a avascular plane, that is no arterial supply, there is no vascularization in this plane. So you can use this plane for incisions. Okay, there will be minimum blood loss. Okay, so you have an avascular plane. Like we have an avascular plane in liver too, we'll see about that. Okay, then talking about the lymphatic drainage of kidney, it is the para-aortic lymph nodes. Para-aortic lymph nodes present at L2 level. Para-aortic lymph nodes present at L2 level. Nerve supplies via renal plexus. Okay, sympathetic nerve T10 to L1. Parasympathetic nerve, that is the 10th nerve. Sympathetic, it is supplied by the T10 to L1. So you can just remember like this, that the kidney was the level of the kidney was T12 to L3. Okay, so the parasympathetic nerve supply is just at a upper level. Okay, just make -2. Okay, that is your T10 to L1, -2. Okay, so you can just remember like this. And the sympathetic nerve is the vagus nerve. Okay, vagus nerve is innervating the kidney. Talking about the clinicals, it's an aberrant renal artery that is present in 30% of population. It arises from aorta and supplies the lower pole of the kidney. So talking about this lower pole, this lower segment is supplied by sometimes your aberrant renal artery, which will supply the lower pole. Then have the polycystic kidney disease. Polycystic kidney disease, if there is like luminal continuity between metanephros and the ureteric bud. Okay, this is the embryological origin. Polycystic kidney disease is of embryological origin, which will read a bit more in your embryology. Okay, I will discuss the embryology of the kidney in a while. Okay, after finishing the pelvic part, we will finish your embryology. Okay, like of this. and the glomeruli continue to excrete the urine. This urine accumulates in the tubule, with which local cystic enlargement will appear. Okay, and this PKD is congenital. This is a congenital disorder. Okay, talking about a horseshoe kidney, we have a horseshoe kidney too. This is the radiograph showing the horseshoe kidney. Okay, this horseshoe kidney is a fusion of the lower poles. You can see here the lower poles. The lower poles are fused, forming the horseshoe kidney. Okay, and another point is that inferior mesenteric artery limit the ascent of the kidney. Okay, your inferior mesenteric artery, this inferior mesenteric artery, okay, this will limit the extent of the kidney. You can see the inferior mesenteric artery coming out like this, so kidney won't extend, kidney can't your extend, okay, upwards. The symptoms of kidney failure: symptoms of extreme fatigue, your nausea and vomiting will be there, your confusion and trouble in concentrating, swelling or edema, okay, poor appetite, cramps, and there will be frequent urination and dry itchy skin. Okay, these are the symptoms of your kidney failure. Understood? So this completes your kidney. Let's move on to the next concept. So let's talk about the ureters. So ureters, this is also an important part, but you can get a short note only. Okay, I won't get a long question. So ureteric constrictions, you have your pelvic constriction, the pelvic constriction, this one. Okay, then you have the pelvic brim at the C2 level. We have the pelvic constriction at the C1 level. Okay, then the pelvic brim at the C2 level. The vast difference is present at C3. Utrovesicular function, utrovesicular junction. Okay, this one, utrovesicular junction, this is at C4, and your ureteric opening is at C5. Ureteric opening is at C5. Okay, so what are the relations? What are the anterior relations? So talking about anterior relations, this is the right kidney and the ureter here, the left kidney, the left ureter here. So anteriorly, what is present? Your second part of duodenum is present here. Okay, your gonadal arteries, your right colic artery and your iliocolic artery, and again your left colic artery and your sigmoidal artery, left colic artery and your sigmoidal artery. Okay, and here you can find the root of the mesentery, and here you can find the root of a sigmoid mesocolon. Okay, root of mesentery and root of sigmoid mesocolon, these are also forming an anterior boundary of your ureter. Okay, posterior relation is the psoas major and the bifurcation of a common iliac artery. The common iliac artery, okay, the CIA comes, this is CIA, and divides into external iliac artery, okay, and internal iliac artery, IIA. Okay, so the junction of your common iliac artery that it is dividing, okay, this is present posteriorly, and the psoas major muscle also. Okay, talking about the blood supply of the ureter, the renal artery, the aorta is there, then the common iliac artery and the internal iliac artery. Okay, this common iliac artery is dividing into external iliac and internal iliac. Okay, so this external iliac artery and the internal iliac artery, these are also supplying this ureteric part. Okay, you have the gonadal artery too, which is giving the supply to ureter, and the renal artery is supplying a pelvic constriction, that the pelvic part of the ureter. Okay, this renal artery. So what are the arteries that are supplying your of your internal iliac artery? There are about 3 branches which are supplying the terminal part of the ureter, that is the inferior vesicular artery in males or inferior vaginal artery in females, your uterine artery, and the middle rectal artery. Okay, middle rectal artery, uterine artery, and the inferior vaginal artery or the inferior vesicular artery. Okay, and it is also supplied with external iliac artery and the branch directly from the common iliac. Okay, and branch directly from the aorta too. Okay, we have the gonadal artery which is supplying, giving innervation, and also your renal artery is supplying the proximal part of the ureter. Okay, talking about lymphatic drainage, again the para-aortic lymph nodes, we talked in kidney too, para-aortic lymph nodes. Okay, the upper part, so kidney, this whole part, this upper part is drained by the para-aortic lymph nodes, the para-aortic lymph nodes, PALN. Okay, this is giving innervation to upper part of your kidney as well as your upper part of your ureter. Okay, and talking about this, your iliac lymph nodes also, iliac lymph nodes which are present in the lower part. For this lower part, we have our iliac lymph nodes. Okay, then we have the nerve supply. The sympathetic nerve supply is from the T10 to L1, the same nerve supply as the kidney. Okay, so the sympathetic, that is the T10 to L1, and parasympathetic is to S2 to S4, which is parasympathetic nerve that is given by your pelvic splanchnic nerves. Okay, so this completes the ureter. Let's move on to the next concept. Let's talk about the urinary bladder now. Urinary bladder. So urinary bladder in children it is abdominopelvic, and in empty it is tetrahedral shape, and if it's full it is ovoid shape. Capacity is 120 to 130 ml. And if the capacity is if the fluid is 220 ml filled, okay, more than this, then you have the desire to micturate. Okay, what are the features? The apex, it's related to a median umbilical ligament, that is a ligament of your uterus. Okay, median umbilical ligament. Then your base is there, then the neck is there, surfaces, superior surface and two inferior lateral surfaces. Borders, you have anterior border, posterior border and two lateral borders. Okay, so this is your bladder. Okay, this is your bladder. The base is formed by this part. This is the base. Okay, this rectovascular pouch, this ampulla of vas deferens and the seminal vesicle. Okay, these are present in this manner. Okay, these are present in this manner. Talking about in males, in your females, the base of the bladder is behind the vagina and the cervix. Okay, the neck is the most fixed part of this urinary bladder, 2 to 4 cm in length, present just behind the lower part of the pubic symphysis. Okay, the neck is present. And in males it is surrounded by prostate gland. The neck of the bladder is surrounded by the prostatic gland. Okay, here it is. Here, look at this. This is the neck part. This is the neck part, which is surrounded by a prostate gland. And in females, the neck is surrounded by a urogenital diaphragm. Talking about the superior surfaces. Okay, so this is the superior surface of your male bladder. Okay, so superior surface is related with the jejunum and ilium are present and is bounded by a peritoneal membrane. In females, we have our cervix present. Okay, this part. Okay, this part is present. Okay, so we have the vesico-uterine pouch, the peritoneum. Okay, and is forming the vesico-uterine pouch. Okay, and the supravaginal part of cervix, which is forming the roof, is forming the superior surface of your urinary bladder in females. Okay, inferior lateral surface. Inferior laterally it is so this is the urinary bladder, and we are talking about the inferior lateral parts. These are inferior lateral parts. So inferior lateral is connected to the puboprostatic ligament or the pubovesicular ligament in case of females. Okay, puboprostatic or pubovaginal ligaments. And we have your obturator internus muscle here and the obturator internus muscle here, covered by your obturator fascia. And this space is called as a retropubic space of Retzius. Okay, so you can see here in this diagram also, there is a space bounded by your medial puboprostatic ligament, the lateral puboprostatic ligaments. Okay, the space bound by the puboprostatic ligaments. Okay, and your umbilicus is there, and this space is called as a peritoneum. This space is called as a retropubic space of Retzius. Okay, and talking about this borders, okay, and surfaces. Okay, we have the apex here, so it is shaped like this. Okay, this is the superior surface, superiorly present. Okay, this is a posterior border. Okay, and this is the base of the bladder. This is the inferior lateral surface. So by superior surface and the inferior lateral surface. Okay, and the base and the superior lateral surface must be present in that part. Okay, this is the anterior border. This is the lateral borders of your bladder. Okay, and this is the posterior border. Okay, anterior border, two lateral borders, and the posterior border. Okay, then now let's talk about the supports of the urinary bladder. Let's talk about the supports of urinary bladder. So, we have the true supports, which are the condensation of pelvic fascia, and the false supports, which are formed in the peritoneal folds. Okay, so we have the true supports like the lateral ligament. Okay, lateral and medial puboprostatic ligament, medial umbilical ligament, and the posterior ligament. Lateral ligament, medial and lateral puboprostatic, median umbilical, and a posterior ligament. These are your true supports. Okay, and for the false supports we have the ligaments which are formed of peritoneal folds, like a median umbilical fold. Two medial umbilical folds are there. Okay, a median umbilical fold and two medial umbilical fold. Okay, and a lateral folds of the peritoneum. Okay, so this you can see, and again a posterior peritoneal folds also. Okay, so these things are there. Okay, so let's discuss this folds in this section. This section is of your urinary bladder. Okay, and we'll discuss the posterior peritoneal fold also in this part. Okay, talking about this, let's discuss. Yes, let's discuss this part. So here you can see a section taken, okay, and your pubic bone and all, okay, it is present in the part. Your rectum is there and the cervix is there, and your that bladder is there. Okay, this rectum, cervix and the bladder is there. So you have the posterior ligament, okay, the posterior ligament, which is a sheet of loose areolar tissue. The posterior ligament that is connecting in this manner, posterior ligament provides space for a vesicular venous plexus, okay, provides space for vesicular venous plexus. It is attached to the lateral side of the bladder, to the lateral pelvic wall. This is the lateral pelvic wall. This is lateral side of the bladder to the lateral pelvic wall, okay, and it allows space for a vesicular venous plexus. And this posterior ligament, you can see, is forming a true support. Is forming a true support for the urinary bladder, okay. Then the lateral ligaments present more laterally, okay, these are forming from your inferior lateral surface. Your inferior lateral surface, this inferior lateral surface, as I told, inferior lateral surface of the bladder to the tendinous arch of pelvic fascia. This is the tendinous arch of your pelvic fascia, okay. So they are connecting it, the inferior lateral surface, to the tendinous arch of your pelvic fascia, okay. Then you have the lateral puborectal puboprostatic ligament, lateral puboprostatic, and the medial puboprostatic ligament, okay. The lateral puboprostatic, medial puboprostatic. So these all ligaments are going from the tendinous arch to the prostatic sheath, tendinous arch to the prostatic sheath. And this medial puboprostatic ligament is also forming the floor of your retzius space, okay. So talking about the retzius space, this was your retzius space, okay. This is the retropubic space of the retzius, and this medial puboprostatic ligament was forming the floor of your retropubic space of your retzius, okay. Understood? Done? Okay, so in females, the pubovesicular ligament is present in place of a puboprostatic ligament, and this is also going to the tendinous arch to the neck of the bladder, tendinous arch to the neck of the bladder. And as in females, the prostatic sheath must not be present, so the neck of the bladder there. Talking about posterior peritoneal folds, you have this S3 level, this S3 vertebrae, okay, and this is called as a posterior peritoneal fold. This is called as a posterior peritoneal fold, two posterior peritoneal folds, okay. Then talking the interior of urinary bladder, okay. So this is the interior of the urinary bladder, okay. So the ureter that is going posteriorly through this, and the ureter is again going posteriorly through this, okay. And here we have the urinary bladder, okay. This is called as a so you have the trigone. Here is the trigone of the urinary bladder, okay. And there are two ureteric openings from which the ureter arise, okay. And this part is called as a bar. This is called interuteric ridge, or your bar of your Mercier, okay. So special names here. So this bar of Mercier is formed by longitudinal muscles of your ureter, okay. This is formed by longitudinal muscles of the ureter, okay. And it is important landmark for a cystoscopy, okay. And then here detrusor muscles are present in the uterus, in your urinary bladder, detrusor muscles are present, okay. And this contractions of this muscle will propel the urine out, okay. And this is the uvula vesicae. This is called as the uvula vesicae. Uvula vesicae is present only in males. It is the median lobe of your prostate gland, okay. The prostate gland is present. This is the prostate gland. It is the median lobe of the prostate gland. It is called the uvula vesicae, and we will talk more about in prostate gland, okay. Then you have the ureterourethral triangle, okay. This bar is called as a Bell's bar, okay. So we talked about this bar is called the bar of Mercier, and this is called a bar of Bell, okay. Understood? Then trigone is smooth as there is no submucosa, okay. The submucosa is absent in the trigone, but this whole parts are they are rough, okay, containing your detrusor muscles. Talking about the blood supply of the bladder, it's supplied by the superior and inferior vesicular artery, obturator artery, and the inferior gluteal artery. In females, it is also supplied by vaginal and the uterine artery, okay. So the superior and inferior vesicular artery, obturator artery, inferior gluteal artery, and in females, vaginal and uterine artery. Talking about the venous drainage, which doesn't follow the arteries, okay. From the vesicular venous plexus, the posterior ligament and the internal iliac vein divides, okay. Like in males, the vesicular venous plexus in males is connecting to the prostatic venous plexus and is supplying the urinary bladder. In females, it is connected to the veins at the base of the broad ligament, okay. Broad ligament of the uterus is connected to the veins at the base of the broad ligament, okay. So vesicular venous plexus is the main drainage system of the urinary bladder, okay. Talking about the lymphatic drainage, in mainly into external iliac lymph nodes, okay, and some also into the internal iliac lymph nodes or your obturated lymph nodes, okay. Talking about the nerve supply of the bladder, we have the somatic nerve supply and the sympathetic chain, okay. So somatic supply comes from an S2 to S3 level, from which your nervi erigitis, these nerves originate and relay into your vesicular plexus. From this vesicular plexus, your pelvic splanchnic nerves, okay, these are like stimulating your detrusor muscles, okay, stimulating the detrusor muscles, and this are also inhibiting the internal urethral sphincter, okay. Inhibiting the internal urethral sphincter means these pelvic splanchnic nerves are generally your causing your micturition to occur. They are compressing the detrusor, it will compress the urine out, okay, and relaxing this internal urethral sphincter so that easily the urine can flow out. If the internal urethral sphincter contracts, then urine can't flow out, okay. And we have from the S2, S3 and S4 divisions, we have our pudendal nerve also, pudendal nerve, which is a parasympathetic nerve supply, and it supplies the external urethral sphincter, okay, and gives positive means it causes the contraction of the external urethral sphincter, okay. And then we have some sympathetic nerve supplies. So parasympathetic, so our urination will be blocked because in parasympathetic conditions the urination will favored, okay, the urination is favored, okay. There will be contraction of external urethral sphincter, okay. And in the sympathetic mechanism, from the T11 to L2, some nerves will come, okay, and sympathetic nerves will come and will relay into hypogastric and vesicular plexus, which will inhibit a detrusor. That means they are the detrusor is not not compressing, so urine can accumulate in the this part, okay. It will give positive to your internal urethral sphincter, so it will contract and urine can't come out. So in sympathetic condition, urination is blocked, okay. And this pelvic splanchnic nerves, these are compressing a detrusor and relaxing the internal urethral, so micturition will occur. Sympathetic filling up bladder will occur, parasympathetic emptying of bladder will occur, and somatic that is under your voluntary control, okay. There are two kinds of fibers in that part, okay, in the urinary bladder, okay. Now the fibers for pain and the fibers for sense of filling, okay. This pass through the posterior white column, okay, these fibers, okay, and this fibers for sense of filling, okay, this will pass through the posterior white column, this part posterior white column, okay. And this fibers for pain, this will pass through the lateral and anterior white column, okay. And if there is anterior lateral chordotomy, that is this part is removed, okay. So it is used to relieve the pain, as the pain won't pass and the pain can't pass. Now this pathway for pain is now relieved, okay. So there will be still awareness of the bladder filling, but and the desire to micturate also remains normal, okay, but the pain is not there, okay. Clinicals, there is a neurogenic bladder, that is a defect in the neural mechanism of the micturiation, okay. So the automatic reflex bladder and the autonomous bladder, okay. So automatic reflex bladder, what is this? Complete transaction above the S2, S3 and S4 of the spinal cord. There is complete transaction above the level of S2, S3, S4, okay. There will be voluntary inhibition and initiation of micturiation is lost, okay. This, if there is transaction above this level, okay. So this nerves won't work, this won't work, okay. This nervi erigitis won't work, and there will be the voluntary inhibition and initiation micturiation is lost, okay. Filling will increase on, okay, and detrusor muscle will contract reflexively, okay, not by any nerve, okay. And the emptying of bladder will occur automatically, okay. Now there will be automatic your automatic reflex bladder, there will be automatic micturiation that will be occurring, okay. In the autonomous bladder, there is a destruction of S2, S3 and S4 segments, okay. When the reflex and neural control is lost, and there will be flaccid bladder, and there will be continuous dribbling with the urine, okay. There will be continuous dribbling of urine. This is autonomous, and this is autonomic bladder, okay. And distended bladder, if the bladder is distended, it will try to try to displace anteriorly, okay. It will try to displace anteriorly. This bladder is trying to displace anteriorly, okay. Understood? So this completes your clinicals of the urinary bladder also. So let's move on to the next part. Let's discuss the uterus. So uterus is also a long question. Just note that uterus is also a long question. Okay, so long axis of uterus is horizontal if the bladder is empty, oblique if it is bladder of if, the bladder is full. Okay, the shape and size, uterus is pear shaped like this. It is shaped like a pear. Okay, this uterus is pear shaped. Length is 7.5, breadth is 5, thickness is 2.5, and the weight is 30 to 40 grams. Okay, so you can remember 7.5 minus 2.5 is 5, 5 minus 2.5 is 2.5. Okay, length, breadth, thickness, and the weight is 30 to 40 grams. Okay, what are the subdivisions? So you have the fundus of the uterus, you have a body. Okay, and then you have the isthmus of the uterus. This is the isthmus. Okay, and the cervix, this is your cervix part, this is your cervix part. Okay, and cervix has two parts also, below, above the vaginal fornix, this is the fornix of the vagina, this is the fornix of the vagina. So above the vaginal fornix we call it as cervix, above the vaginal fornix, and cervix below the vaginal fornix. Okay, the normal position axis, there is an angle of anteversion and the angle of anteflexion. Okay, angle of anteversion and the angle of anteflexion. So from the long axis of the cervix, this is the long axis of cervix. Okay, and this is the long axis of a vagina. This is the long axis of a cervix, and this is the long axis of a vagina. Okay, so there is an angle between them which is 90 degree. Normal angle is 90 degree, that is called the angle of anteversion. What is the angle of anteflexion? Okay, so if there is a long axis of cervix like this, and the long axis of body that is lying like this. Okay, so if the long axis of body of the uterus, and the long axis of cervix, so there is obtuse angle formed, that is of 150 degree to 170 degree. This is called as the angle of anteflexion, angle of anteflexion. Okay, then what are the relations of the uterus? This is very important. What are the relations? You can easily write. Okay, and you can write about the lateral borders, and the I will talk about the cavity and the ligaments at last, ligaments and the arterial supply, lymphatic drainage. So we have to discuss a lot of things. Okay, as it is an important long question. So in the anterior relations, this is your uterus. Okay, and here in the anterior relation you will have your urinary bladder present, the superior surface of the urinary bladder. Okay, superior surface of the urinary bladder, and the utrovesicular pouch. This is the utrovesicular pouch that will be present here. Okay, and here this will be the relations of the body of the uterus, the anterior relations of the body of the uterus. Okay, and this base of the bladder, okay, the base of the bladder, and the anterior fornix, the base of the bladder, specifically, this base of the bladder specifically will form the anterior relation of the supravaginal part of cervix, in this part, and the relation of the anterior relation of this infravaginal part will be your anterior fornix of the vagina, Okay, this is the anterior relation of the infravaginal part. Okay, and the posterior relation of the body will be your coils of jejunum and ileum. Okay, these are your coils of jejunum and ileum, which will be forming the posterior relation of the body of the cervix. Okay, and the posterior fornix and the rectouterine pouch, the posterior fornix as well as the rectouterine pouch, which is also called the pouch of Douglas. Okay, and the posterior fornix, these are forming the relations of the cervix. Okay, so you can write the relations of all these parts. Just you have to draw this diagram correctly. Okay, and write the parts. Okay, but the lateral relation, is bound with the broad ligament. Okay, so the broad ligament will be forming a lateral boundary, and in the upper part, in the fundus part, round ligament of uterus, fallopian tube, and the round ligament of ovary, fallopian tube, and the round ligament of ovary, these are present in the lateral relations also. Okay, if this is the fundus part, then if the round ligament of uterus like this, it will move through the inguinal canal. Okay, and of this fallopian tube, there will be the round ligament of ovary, which will connect the uterus to the ovary. Okay, so the round ligament of ovary and the uterus, which will also form the lateral boundary. Okay, and then talking about the cavity, we have the uterine cavity, we have the cervical canal here, uterine os here, this is the uterine os present, and the external os. Okay, the external os, it is circular in nulliparous women who don't have children. Okay, and horizontal slit, this is horizontal in shape. Okay, in case of a multiparous woman having multiple children, in childbearing women. Talking about ligaments of the uterus, this may be false ligaments or these may be true ligaments. False ligaments are peritoneal folds, so true ligaments, these four are true ligaments. False ligaments, we have the broad ligament, utrovesicular fold or anterior ligament, or rectouterine fold or your posterior ligament. Okay, Like you must have observed, we have a utrovesicular pouch. Okay, so the fold of the utrovesicular pouch, this is the anterior ligament, and the rectouterine pouch is there. So the the surface of the rectouterine pouch, okay, that is called the rectouterine fold, which is called as the posterior ligament, and we have a broad ligament. Okay, talking about the broad ligament, it has anterior and posterior surfaces and two lateral borders. Okay, this ligament has anterior and posterior surfaces and two lateral borders. It has four parts: your mesosalpinx, mesovarium, mesometrium, and your infundibulopelvic ligament. Okay, infundibulopelvic ligament, mesosalpinx, mesovarium, mesometrium, and infundibulopelvic ligament. Okay, talking about the false ligaments, these are your false ligaments. And your true ligaments, what are the true ligaments of the uterus? So you have the round ligament of the uterus, you have the transverse cervical ligament, round ligament, transverse cervical ligament, that is called the cardinal ligament, uterosacral ligament, and then pivocervical ligament. Okay, round ligament, then your transverse cervical ligament, uterosacral ligament, and your pivocervical ligament. These are the true ligaments. Okay, so let's talk about all these ligaments. So broad ligament has mesosalpinx, mesovarium, mesometrium, and infundibulopelvic ligaments. So you can see here. Okay, if this is the uterus. Okay, then you have a fallopian tube here. You have a fallopian tube here. We'll discuss the fallopian tube in detail. And that's the ovary, and this part is called as the mesosalpinx. So I talked about the broad ligament. Okay, so let's continue from that. Parts, we have the mesosalpinx, mesovaria, mesometrium, and the infundibulopelvic ligament. Okay, just see the part. The mesosalpinx, this is a mesosalpinx that is connected, and that is connecting your fallopian tube, okay, and the ligament of ovary, and to the ovary itself, okay, and to the fallopian tube, the infundibular part of the fallopian tube. Okay, this is your mesosalpinx, and this is your mesometrium. Mesosalpinx is this one, mesometrium is this one. This is called as a ligament of ovary, which is connecting it to uterus. Ligament of ovary connects the ovary to the uterus. Okay, and this is called as infundibulopelvic ligament, which is firmly holding the infundibulum part. Okay, so this is that. And mesovarium is not seen in this illustration. It connects ovary to the posterior wall, understood? After that, let's talk about the contents of the broad ligament. What are the contents of the broad ligament? So in the broad ligament, we have these parts. So what is the content? You have the uterine artery here that is running in this manner. Okay, and it is anastomosing with ovarian arteries. Okay, the ovarian artery divides and anastomoses with one part of it, uterine artery. Okay, and another, it gives a branch to the uterine artery. It also gives a branch to the ovary itself. Okay, and ovarian artery, of course, it supplies the ovary. Understood? So we have the uterine tube, that is a fallopian tube. The fallopian tube is contained within the broad ligament. We have two ligaments, that is a round ligament of ovary and the round ligament of uterus. Okay, we have the round ligament of ovary and the round ligament of uterus, which is not visible in this diagram. We have the two arteries, which is the ovarian artery and the uterine artery. Two plexuses, that is the ovarian plexus and uterovaginal plexus. Embryological remnants, that is Gartner's duct and vestibular appendices. Okay, vesicular appendices. Okay, so we have an appendix, that is the vermiform appendix, that is in abdomen. Okay, and we have a vesicular appendix also. Okay, so that is that. And your fatty tissues and lymphatic tissues and lymph nodes. Okay, so two embryological remnants which you have to remember, that is your Gartner's duct and your vesicular appendix. Okay, and two plexus, ovarian plexus, uterovaginal plexus. Talking about the arterial supply of the uterus, so we have two uterine artery and two ovarian artery which are supplying the uterus. Okay, talking about the uterine artery, so uterine artery is coming here like this. Okay, it is giving a branch to the ureter. We saw from the previous discussion. Okay, and this also gives this branch to the vagina also. This is the vaginal branch of the uterine artery. Okay, and to the cervix also. So cervical branches. And here we have arcuate arteries. Arcuate arteries are supplying this part, the body of the uterus. Okay, and we have the ovarian branch also. This is the ovarian branch, which is giving tubal branches to the fallopian tube, and another branch is the ovarian branch to the ovary. Okay, so this tubal branches, these are supplying medial 2/3 of the fallopian tube itself. Okay, so this is the whole arterial supply of the uterus. You can draw this diagram if it is asked. Talking about the lymphatic drainage, so from this fundus and half of the body part, it drains into your pre-aortic lymph nodes and the para-aortic lymph nodes. Okay, mainly to the pre-aortic lymph nodes. These para-aortic lymph nodes are like utilized. Also this can also cross this and move to the para-aortic lymph nodes also, so it can consider this also, but less amount. Okay. And then you have your superficial inguinal lymph nodes. Okay. Superficial inguinal lymph nodes, this part, the junction between your uterus and the fallopian tube. Okay, this part is draining into the superficial inguinal lymph nodes. Okay, and you can see the blue part that is draining into your external iliac lymph nodes, okay. And from this lower part, it is draining into your sacral lymph node. Okay, your internal iliac lymph node and your external iliac and your obturator lymph node. Okay, so you have four. This sacral lymph node you can consider, okay, sacral lymph node and your internal iliac lymph node and your obturator lymph. Okay, if you want you can write your external iliac lymph nodes also. Okay, then we have the supports of the uterus, which are very important, and you may get a short note on the supports of the uterus. So primary support and we have secondary support. And primary support we can have muscular supports, visceral supports, and fibromuscular supports. Okay, muscular, visceral, fibromuscular. So the pelvic diaphragm, in the muscular support, pelvic diaphragm, perineal body, and urogenital diaphragm. In the visceral support, you have the urinary bladder, vagina, and the uterine axis. In the fibromuscular support, that are the true ligaments of the uterus. Very important, transverse cervical ligament, which is also called as the ligament of Mackenroth. Okay, transverse cervical ligament, also called as the ligament of Mackenroth. Pubocervical ligament, uterosacral ligament, and the round ligament. Okay, so transverse cervical, pubocervical, uterosacral, and the round ligament. These are your true ligaments. Okay, which comprise of the fibromuscular support. Okay, and the secondary support, we have the broad ligament, utrovesicular fold, and the rectouterine fold. Broad ligament, your utrovesicular fold, and your rectouterine fold. So talking about these supports, you can just draw this diagram. You will get more than enough marks. Okay, so if this is a sacrum, okay, so this part is a transverse section. This is a transverse section. So if you have the rectum here, you have the cervix here, and you have the body of the urinary bladder here. Okay, and from this your uterosacral ligament, this is a uterosacral ligament which connects to the first to third sacral vertebrae. This is a uterosacral ligament. Then you have the transverse cervical ligament, which is called as the cardinal ligament. Why it is called the cardinal ligament? It is the most important support and it prevents uterine prolapse. Okay, how is it formed? It is formed by condensation of pelvic fascia around the uterine vessels. Okay, so it is called as the cardinal ligament of the uterus. That is a transverse cervical ligament. It is one of the main ligaments. Okay, then a pubocervical ligament, that is corresponding to your puboprostatic ligament in the case of your males. Okay, and this is the pubic symphysis. Okay, so these are your ligaments which are transverse cervical, pubocervical, uterosacral, and the round ligament. The round ligament is not visible here. Okay, this is a round ligament which is pulling the uterus in this manner. Okay, this round ligament will pull the uterus in this manner, causing an anteflexion, the angle of anteflexion, and that angles you studied about the angles, you know, your angle of anteversion and angle of anteflexion. Okay, so these angles are formed due to this round ligament only. Okay, so we have this round ligaments which are causing this. Understood? And this uterosacral ligament, this is pulling in this direction. Okay, this is pulling in this direction, this is pulling in this direction. So this maintain the angle of anteversion and anteflexion. Understood? So this round ligament and this uterosacral ligament are maintaining the angle of anteversion and your anteflexion. So this completes the uterus. Let's move on to the next concept. Let's talk about the uterine tube, that is the fallopian tube. Okay, so this is a fallopian tube where you have many parts. Okay, specifically 4 parts. Let's talk from this part. Okay, so I have this projections, this extensions which are called as fimbriae. Okay, and this whole part, this blue part, is called as your infundibulum. It is about 1 cm in length. This is the infundibulum, and the longest of this fimbriae is called as the ovarian fimbriae. Okay, if we consider this as the longest, it will be called as your ovarian fimbria. Okay, and this infundibulum have the process of when the ovary releases an ovum, this fimbria, they move and capture this ovum back. Okay, so this is the function. And let's talk about the other parts. That is ampulla part. It's the most dilated part. Okay, widest and the longest part even. It is about 5 cm. Okay, and you have the abdominal ostium where there is the communication. Okay, and at this ampulla part, the ovarian artery and the uterine artery, this generally, anastomose. Okay, then of the isthmus part which is 2.5 to 3 cm long, and it is straight and thick walled. Okay, the walls are thick. And we have the intramural part that is also 1 cm in length. This is the intramural part. And now you have the uterine ostium. Okay, now the uterus will be there. Okay, so intramural part is situated at the junction of the body and the fundus. Okay, so this completes your parts of your fallopian tube. Let's discuss the arterial supply. So we have the ovarian artery, which supplies the lateral 1/3, and the uterine artery supplying the medial 2/3. Okay, so this uterine artery is supplying the medial 2/3, and this ovarian artery is supplying the lateral 1/3 of the fallopian tube. Okay, venous drainage is corresponding to the artery. You have the ovarian vein and the uterine vein. Okay, this lymphatics, we have the internal iliac lymph nodes, pre-aortic lymph nodes, and the para-aortic lymph nodes, which the lymph is draining from these parts. Okay, the nerve supply sympathetic T11 to L2, T11 to L2, and parasympathetic we have S2, S3, S4, S2, S3, S4. Talking about clinicals, so we have the salpingitis. Salpingitis is the inflammation of fallopian tube and can cause uterine tube block. Okay, patency of uterine tube can be tested by your insufflation test, okay, or Rubin's test, and your hysterosalpingography. Okay, this is an advanced technique. Okay, this HSG test. Okay, so what happens, you inject a dye from the vaginal opening. Okay, the dye is injected through a cannula, and this dye and this excretion spillage of the dye indicates that the tubes are open. Okay, and if there is no spillage, then it can be considered that the tubes are blocked. Okay, so and what is insufflation test? This is air is pushed in the uterine tube, and if air leaks out of the abdominal ostium, this air, the air that is injected, okay, this leaks out of this abdominal ostium if the tubes are open. Okay, and there is a bubbling sound which can be heard by stethoscope on the iliac fossa. Okay, this bubbling sound, the air spillage sound will be heard by putting a stethoscope on the iliac fossa. Okay, so this you can see, this is a HSG test. Okay, hysterosalpingogram. Okay, and you can see the spillage of dye. Okay, the dye has been leaked in both parts. Okay, the dye is present here also and present here also, so it indicates that your uterus, the fallopian tube, it is very normal. Okay, so you have the open tubes. So to check if there is uterine tube block or not, we apply these tests. Okay, and we have a Cartagena syndrome, that is immotile cilia syndrome. You must have read biochemistry also. If you haven't, let's discuss this. So what happens if you have immotile cilia? The cilia due to any mutation also, okay, the cilia become immotile. Okay, they aren't able to move. Okay, due to which the fallopian tube is the site of fertilization, right? So the site of that fusion of gametes. So in fallopian tube, your ectopic pregnancy may occur due to that. Okay, so the ectopic pregnancy may occur due to immotile cilia, which is called as a Cartagena syndrome. Understood? So this completes your fallopian tube, and you know the ampulla or your ampullary isthmic junction. Okay, this is the site of the fertilization, and here the fertilization occurs. So after completing the uterine tube, let's move on to the next part. Let's discuss the ovary. So ovary, it is also a very important part. So it has two poles. That is the upper pole and the lower pole. It has two borders, anterior, posterior, two surfaces, medial, lateral. Okay, medial, lateral. So what is the location in nulliparous women? Nulliparous women means the birth of baby hasn't occurred. Okay, so it is called the nulliparous woman. Okay, so you have the urinary bladder here. Okay, and the ureter is like this. Okay, so you have the ovary here. The ovary is present over here. Okay, in this part. Okay, the ovary is present in this part. This green structure, you can see the ovary is present. Okay, and the cavity in which the ovary is present is called as the ovarian fossa. Okay, and what are the relations? You can see you have your external iliac vessels. In the anterior relation, you have the external iliac vessels. Okay, and the posterior relation, you have the internal iliac vessels like this, internal iliac vessels, and the ureter, which is present posteriorly to the ovary. Okay, and the floor is from the obturator nerve and vessels. This obturator nerve and vessels, these are forming a floor of the ovary. Okay, we talked also this about in your lower limb. Okay, obturator nerve, I showed that it is lying just beneath the ovary. Okay, so it forming the floor of the ovary. Understood? So anterior relations, posterior relations, and the floor we saw. Okay, talking about this. And this ovary, how it is connected to the ligaments and the uterus, how it is related. So this is the uterus, and here you have the fallopian tube. So this the fimbria fallopian tube are holding it, okay, and there is a ligament here, okay, which is connecting it, okay, and this is called as a round ligament of ovary. This ligament is called as a round ligament of ovary, and this is a lower pole, this is a lower pole, this is the upper pole, okay. And infundibular ligament, this is the infundibular ligament which is holding it, which is called as the suspensory ligament of ovary, okay. So the infundibulum is holding the ovary by this infundibular ligament or the suspensory ligament, and this round ligament of ovary is connecting the ovary to the uterus. Understood? It is easy, okay, it is easy, you can just see, okay. If we take a transverse section, then you have your ureter, you have your uterus here, and the ovary is present over here, and this ovary, let's see. So this one first, this ligament is called the suspensory ligament of ovary, you know this, okay, suspensory ligament of the ovary, okay. And this is the ovarian artery which must be passing like this, okay. And we have the broad ligament, the anterior part, this is the anterior broad ligaments. So this part is actually the suspensory ligament of ovary, this one which is suspending the ovary, right? This part, suspensory ligament of ovary, is suspending the ovary to the fimbria, okay. So this whole part, okay, this three parts are generally combining to form a suspensory ligament. What are the three parts? Your anterior border of your broad ligament, okay, your posterior border of the broad ligament, okay, and your ovarian artery. These three are forming a suspensory ligament of the ovary, and combinedly, these three combinedly is called as a mesovarium, okay, which is present in the anterior border of the ovary. It is adhered to the anterior border of the ovary, okay, and posterior border of the ovary is free. Arterial supply, we have the ovarian artery L1 level from the abdominal aorta, and ovarian branch of a uterine artery, which is formed from the anterior division of internal iliac artery. Venous drainage is via the pampiniform plexus, okay, venous drainage is via the pampiniform plexus, which becomes a single vein at the level of pelvic inlet, okay, right ovarian vein and the left ovarian vein. Right ovarian vein drains into IVC, and left ovarian vein drains into a left renal vein, okay. And this is a pampiniform plexus. You can see the plexus type network. This is a right ovarian vein, the left ovarian vein present over here, okay, you can see this. Then lymphatic drainage, we have the pre-aortic and para-aortic lymph nodes, nervous innervation, sympathetic T10, parasympathetic S2 to S4, okay. That's how ovarian pain is referred to the umbilicus. Ovarian pain is referred to the umbilicus, okay, because the segment that is also draining the umbilicus, that is also sympathetic nerve, that is also the T10 level. So ovarian pain is often referred to your umbilicus. Clinicals, we have the ovarian torsion. Ovarian torsion means that is because of long mesovarium, the ovary becomes torsated, like the ovary rotates, okay, in this part. So torsion of vessels and ligaments will also be there, due to which there will be vessel congestion and hemorrhage, okay. So this is called as the ovarian torsion. This is a normal ovary, and if torsion occurs, this appears like this, okay. Then ovarian prolapse. Ovarian prolapse is seen in the pouch of Douglas. Pouch of Douglas is a rectotrain pouch, okay. It can be felt in the pervaginal examination, PV examination. And ovarian cancer consists of 15% of total cancers, okay. You have the type 1 and type 2. We don't have to go into detail, you can read this if you want, okay. You can take a screenshot. Done? Yes. So that completes your ovary, and now let's move on to the next part. Let's discuss about the male part. So we have the testis to discuss. It is a male gonad, and your left testis is slightly lower than the right testis. Weight is about 10 to 15 gram. You can see the structure. So you have the ductus deferens, okay, the vas deferens, the ductus deferens, and this part is called as the epididymis. This is the epididymis, okay. And we have the paradidymis here, and superior aberrant ductules are present over here, some, okay. And I have this yellow part, you can see it is called as a sinus of the epididymis, okay. This is the upper pole and this is the lower pole, and we have the inferior aberrant ductule, okay, and the superior aberrant ductule present over here. So in external features, we have two poles, upper pole, lower pole. Upper pole is related to your appendicitis. It is also called, or it is related to the appendix of the testis, okay, which is a remnant of your paramesonephric duct, okay. Then two borders, anterior border and posterior border. Posterior border is epididymis lies like lateral to the posterior border, okay. Epididymis lies lateral to the posterior border. and then two surfaces, medial surface and your lateral surface. So two posts, two borders, two surfaces. This is about testis. And we have the inner structure of testis. We have in the lobules, testis is divided into lobules, and in each lobule you have 1 2 3 seminiferous tubules. Okay, and the seminiferous tubules are convoluted. This convoluted seminiferous tubules combine to form a rete testis. This rete testis then forms efferent ductules. This efferent ductules combine to form an epididymis. Epididymis comes and forms a vas deferens, and from here it goes via this in the bladder and all. You can see the relations from there. Okay, so if there is a transverse section of the testis and epididymis, you can see, okay, what are the things that are formed. Okay, you can take a screenshot of this also. I'm not going into much detail here. Covering, what are the coverings of the testis? So we have the tunica vaginalis, tunica albuginea, and the tunica vasculosa. Tunica vaginalis is the outermost covering. Okay, it covers the whole testis except its posterior border. Tunica albuginea is a dense white fibrous coat. Okay, and tunica vasculosa is the innermost part, and it is vascular. Okay, so tunica vaginalis, tunica albuginea, and the tunica vasculosa. Tunica vaginalis is the outermost part, which covers the whole testis except the posterior border. Albuginea is the dense white fibrous connective tissue, and vascular is the innermost part, and it is vascular. Inner structure, we have your 200 to 300 lobules, where each has 2 to 3 seminiferous tubules. This is joined and form 20 to 30 straight tubules. The straight tubules form your rete testis. This rete testis form 12 to 30 efferent ductules which enter the epididymis. Okay. Your arterial supply is the testicular artery, which is a branch of abdominal aorta at L2 level. Venous drainage is via the pampiniform plexus. Lymphatic drainage is via the pre-aortic and para-aortic group of lymph nodes. Nerve supply, what is the nerve supply? Your sympathetic nerves from the T10 segment. Okay, it's supplied by the sympathetic nerves from the T10 segment. Okay, so you can see your pampiniform plexus again. Okay, this pampiniform plexus goes via the deep inguinal ring. Okay, and on this right side it goes via the superficial inguinal ring. Okay, and it joins the right testicular vein and the left testicular vein. This left testicular vein drains into a left renal vein, and this right testicular vein drains into your inferior vena cava. So understood? So if you understood about the pampiniform plexus, this is about histology of seminiferous tubules and the epididymis. Okay, so this is seminiferous tubules and the epididymis. You can see here. Okay, this is lumen, and as you go from the towards the lumen, okay, the maturity increases. That is a spermatogonium that must be present in the this part, the superficial part. And as you go down, there's a spermatogenesis occurring, and here in this luminal side you will have your other things, that is your spermatozoa. Okay, so spermatogonia, then your primary spermatocyte, your secondary spermatocyte. You can see spermatogonia, primary spermatocyte, secondary spermatocyte, and your spermatids. Okay, so this is about your histology. Talking about clinical, so we have the monorchism. Monorchism is the unilateral presence of testis. Okay, anorchism is a bilateral presence of testis. Cryptorchism is the undescended testis in children. Ectopic testis means abnormally placed testis. Okay, hermaphroditism is the both testis and ovary are present in the same individual. Okay, what are the positions for ectopic testis? It may be present in the lower part of abdomen. Okay, lower part of abdomen. Okay, or it may be present in the front of thigh, or it may be present in the femoral canal or a skin of the penis. Okay, or it may be present behind your scrotum. Okay, and what is varicocele? Varicocele is the dilation of pampiniform plexus, which will the fluid accumulation will occur. Okay, and it is usually left sided. Understood? And then you have the blood testis barrier, which was a PYQ, or this is called a Sertoli cell barrier. It is a physical barrier between blood vessels and the seminiferous tubules of the testis. Okay, it is not strictly a blood organ barrier. Okay, but it is formed between your Sertoli cells and isolates further developed stages of germ cell from the blood. Okay, so it is also called as a Sertoli cell barrier. So connections after the forming of blood testis barrier, it's tight junctions, adherence junctions, and the gap junctions. But the functions, it allows the Sertoli cell to control the adluminal environment. So Sertoli cell is basically controlling the environment which is required for the germ cell development. It prevents the passage for cytotoxic agents and noxious agents which may inhibit your spermatogenesis and all. It maintains the composition of ions and hormones inside the lumen and prevents an autoimmune response against the sperm. Okay, prevents an autoimmune response against the sperm. So this was all about your testis. Let's move on to the next part. Let's talk about your male urethra. So in the male urethra, you can have your three parts: your prostatic urethra, membranous urethra, and the penile urethra, which is a spongy urethra. Okay, so you can have a urinary bladder here, the trigone of the bladder and all. Okay, this comes down, and where the prostate gland is present, it is called as the prostatic urethra. So it is about 3 cm. The prostatic urethra is about 3 cm. Then when you have the external urethral sphincter present, external urethral sphincter, okay, and your bulbourethral glands are also present in this part. Okay, so you have a membranous urethra in that part. Your external urethral sphincter is present in this part. Okay, 1.5 to 2 cm. And then you have a dilated part here, which is called as a intrabulbar fossa. Okay, intrabulbar fossa, and these glands are your intrabulbourethral gland. Okay, below this part, it is called as a penile urethra or a spongy urethra. Okay, and we have some lacunae present over here. It is called a lacunae of Morgagni. Okay, and you have a fossa, that is a navicular fossa in this part, a dilated part. Okay, and this part is called as a lacuna magna or a sinus of Guerin, which is the most prominent lacuna that is present. Okay, it is called as a this whole part is called as a lacuna of Guerin. Okay, lacuna of Guerin or the sinus of Guerin, and also your lacuna magna. Okay, and this is a glans, you can see. And this bulbourethral, this intrabulbar fossa, this is about 3 cm in length. You can remember the cms. Okay, and the longest part is the penile urethra, that is about 15 cm. Okay, urethral glands are called as Litter's glands. These are present throughout the spongy urethra and open into the lacuna of Morgagni. Okay, so the ducts, the openings of the urethral glands, or the Litter's glands, these are your lacunae of Morgagni. Okay, and what is about prostatic urethra? It is the widest part and the most dilatable part or distensible part. Okay, so this whole part is your coronal section of a prostatic urethra. This is a section of the prostatic urethra. So you have your prostate glands present over here. These are the prostate glands, the two lobes. Okay, medial lobe will be present over there like that. This part is called as a urethral crest, where the extension of trigonal muscles occur. Okay, and this whole part is is a bit dilated. Okay, and here you can see three parts, that is opening for ejaculatory ducts. The ejaculatory ducts are opening here. Okay, and in this blue region, this is a prostatic utricle, which is the remnant of your posterior your post mesonephric duct. Okay, the posterior mesonephric duct opens into the prostatic utricle. Okay, and this dilated part is called as a prostatic sinus. Okay, and the duct of prostate gland open in the sinus. These green structures are the ducts of the prostate gland. Okay, which open in the sinus. So you can draw the coronal section of the prostatic urethra. Okay, then we have the sections of urethra at different level. How the sections look like? If you take a transverse section here, it will look like a horseshoe shaped. Okay, of your membranous urethra transverse section, it will look like a star shaped. Okay, and this fossa that was present, that is an intrabulbar fossa. At the level of this intrabulbar fossa, if you take a section, okay, it will be shaped like a trapezium, and here the penile urethra transverse section will be like horizontal slit. It is flattened, in fact. Okay, and if you take the section of the glans, it will be like a vertical slit. Okay, and what is hypospadias? This is a congenital anomaly where the external urethral orifice is not located, is located on the internal or the ventral aspect of penis instead of this part. Instead of your external or urethral orifice is located in this part. Okay, but if it is present abnormally in various parts, okay, it is called as your hypospadias. Okay, and 1 to 5, these are the possible locations of the hypospadias. Okay, where if your external urethral orifice is located in the glans region, we call it as glandular hypospadias. Okay, and in this region it is called as the balanic hypospadias. This part in the shaft, okay, we have a penile hypospadias. Okay, and the junction of your penis and the scrotum, this is called as a penioscrotal hypospadias. And if it is located in the scrotum, it is called as a perineal hypospadias. Okay, so this is all about your hypospadias. Okay, so this completes your male urethra. Let's move on to the prostate gland now. Let's talk about the prostate gland. So mark that prostate gland is also a possible long question. Okay, you can get a long question on the prostate gland. So it is a inverted cone shaped gland. Okay, weight is about 30 gram and width is 4, length is 3, and the thickness is 2. Okay, you can remember WLT 432. Okay, width is 4, length is 3, and the thickness is 2. Okay, and talking about the prostate gland, this is a prostate gland. You can see this whole part is a prostate gland. Okay, and what are the lobes? You have the anterior lobe of the prostate gland. This is the anterior lobe, blue part, anterior lobe. The yellow one is the lateral lobe. Okay, and you have a medial lobe, that is medial lobe, and you have a posterior lobe. You have the posterior lobe. This whole part is the posterior lobe. Okay, so this is your prostate gland. You can see it is bounded. Pelvic diaphragm is present in this manner, the urogenital diaphragm, and then this green one is your pelvic diaphragm and the urogenital diaphragm you saw, and this is a fascia that is covering it. Okay, so afterwards you have features that are apex, base, and four surfaces. You have four anterior surface, posterior surface, and two inferior lateral surfaces. Okay, anterior, posterior, and two inferior lateral surfaces. Apex faces the urogenital diaphragm. The apex of the gland faces the urogenital diaphragm. Apex of the gland faces the urogenital diaphragm. Base is related to the neck of the urinary bladder. Okay, base is related to the neck of the urinary bladder. So the base is related to the neck of the urinary bladder, this part. Okay, and then again, what is the okay, it is pierced by urethra at the junction of anterior 1/3 and posterior 2/3. Okay, this base is pierced by the urethra at the junction, like it will be 3D in this manner. Okay, so it is pierced by the urethra in the junction of your anterior 2/3 and your posterior 1/3. Okay, talking about surfaces, it has an anterior surface which is present 2 cm behind the pubic symphysis and is separated by the space of Retzius. We talked about the space of Retzius also in previous one. And then we have the posterior surface. Posterior surface is like this, shaped like this. Okay, we have your transverse sulcus. This is your transverse sulcus, the medial lobe, and these are your lateral lobes, two lateral lobes. Okay, and in this transverse sulcus you can have your openings of your ejaculatory duct. Okay, and then you have a posterior median sulcus. Okay, this is a transverse sulcus and the posterior median sulcus. And your inferior median surface, this is related to the levator ani. Inferior median surface, it is related to your levator ani muscle. Okay, what are the lobes of the prostate gland? So it has 5 lobes. Just note that it has 5 lobes. Okay, we have an anterior lobe like this, a medial lobe like this. Okay, you have a median lobe like this, anterior lobe, median lobe. Okay, and you have a posterior lobe. Okay, so this is the sagittal section of your prostate gland, and the anterior lobe, it is in front of the urethra, which connects both the lateral lobes. Okay, so like anterior lobe, you can't, like, you have to visualize in 3D. Of course, you have to visualize in the 3D so as to get an orientation, but here we can't see in that 3D. Okay, so we have to just manage with it. Afterwards, we have this anterior lobe is devoid of a glandular tissue. Talking about the median lobe is behind the upper urethra, in front of the ejaculatory duct. Okay, it is behind the upper urethra, in front of the ejaculatory duct. Okay, so this is the median lobe. This one is the median lobe. Okay, and it is in front of your ejaculatory duct. And behind the upper urethra. It produces the elevation, the apex of the trigone. We talked about the median lobe, which was producing an elevation, which that elevation, which is called as the uvula vesicae. Remember, in the urinary bladder, while discussing about the uvula vesicae, which was an elevation of the prostate gland, median lobe of the prostate gland, and loads of glandular tissue is present. So it is the most common site for the adenoma. Okay, and lateral lobes, there's some glandular tissue is also present here. We have the posterior lobe that is present behind the urethra and below the ejaculatory ducts. So you can just see, okay, it is present behind the urethra and below the ejaculatory ducts. Okay, so this is your posterior lobe. Structures within the prostate gland, you have the prostatic urethra, ejaculatory ducts, and the prostatic utricle. Okay, so prostatic urethra, this runs through the prostate between the anterior 1/3 and posterior 2/3, opens on the anterior surface near the apex. This ejaculatory ducts are present and the prostatic utricle is also present. Talking about the capsule, we have a true capsule and the false capsule of the gland. Okay, true capsule and a false capsule. We'll talk about the supports and the structures of the gland also. Okay, arterial supply, venous drainage, lymphatic drainage, nerve supply, and age-related changes. Okay, no problem. We'll talk about that. So this capsule is a true capsule, that is the condensation of gland's own stroma. Of course, all the organs have the true capsule, that is a condensation of their own stroma only. False capsule is formed by condensation of the pelvic fascia. Okay, so this is the prostate gland. This is the whole prostate gland. This is present like this. This is prostate gland. This is the prostate gland. The lobes. Okay, so the true capsule, you can see it is a condensation of the gland's own stroma. Okay, and it contributes to the vesicular venous plexus. Okay, and to the prostatic venous plexus also. Afterwards, this is a false capsule. This is a false capsule which is surrounding the gland like this. Okay, and this false capsule formed by condensation of the pelvic fascia. From the clinicals now, that is this portion, this if there is the prostatectomy, okay, prostatectomy, this portion of the gland is removed, okay, this portion of the gland is removed in prostatectomy, okay. Some part is left out in situ so as to not damage the venous plexuses, okay. So some part of it is left out in situ so as to not damage the venous plexuses, because the venous plexuses are like intrinsically connected to the gland, okay. So some part is left out like this, some part is left out like this part is left out so as to not to damage the venous plexuses. What are the supports? We have the urogenital diaphragm, the two puboprostatic ligament, and the rectovesicular fascia of Denon villus. Rectovesicular fascia of the Denon villus. This is a rectovesicular pouch or the rectouterine pouch or the pouch of Douglas. Okay, and then we have a fascia like this, which is called as your retrovesicular fascia of the Denon villus. Okay. Talking about the structures of the prostate gland, we have the fibrous tissue in 1/4 of the gland. Okay, we have muscular tissue 1/4 of the gland, and glandular tissue half. Okay, so majorly it is formed of glandular tissue where tubulo-alveolar glands are present. Tubulo-alveolar gland. Okay, so you can just see this. Okay, this green part is the false capsule. This whole part is the true capsule, that is your gland's own stroma. Okay, and we have our PVP, that is your the venous plexus, that is your venous plexus of the prostate gland. Okay, prostatic venous plexus, you can say. Then afterwards we have the glands present in this region. This isthmus is called as the anterior lobe of the prostate gland. Okay, this isthmus is the anterior lobe, and we have the glands like this. We have mucosal glands like this in the inner part. Mucosal glands are like this. So we have what we have done is we have taken section of the transverse section of the gland. Seeing the mucosal glands are shown in the red. Okay, then you have the submucosal glands which are present around the mucosal glands like this, and then you have the prostatic glands proper. These are your prostatic glands proper. Okay, and you know about the tubulo-alveolar gland, like a gland is like this. Okay, and it is like shaped like this. Okay, it is shaped like this. This is a tubular part, and we have the alveolar part of the gland. Okay, so this type of glands are your tubulo-alveolar glands. Okay, we know about this. Okay, and we have three types, that is the mucosal gland, submucosal gland, and the prostatic gland proper. Okay, and we have the inner zone, okay, containing your mucosal glands and the submucosal glands, and the outer zone containing your prostatic glands proper. Okay, so mucosal glands, this open above the seminal colliculus. Okay, this open above the seminal colliculus. Submucosal gland at the level of seminal colliculus, and your prostatic glands proper, which are in your outer zone, is open below the level of seminal colliculus. Okay, understood? So this is the thing. And the arterial supply is by inferior vesicular artery, middle rectal artery, and the branch from the internal pudendal artery also. Inferior vesicular, middle rectal, and internal pudendal. Okay, then with the venous drainage is your prostatic venous plexus, the main part. Okay, so what happens is that we have a prostate carcinoma that can metastasize to brain. Okay, and can reach the venous sinus. Okay, so what happens in the prostatic venous plexus? The veins are drained into prostatic venous plexus, and this goes via the posterior ligament of the bladder. Okay, to the internal iliac vein. Internal iliac vein joins the common iliac, and it goes to the inferior vena cava and to the heart. Okay, so what happens, this prostatic venous plexus, this communicates with the sacral foramina. Okay, and the sacral phenomenon is connected to the vertebral venous plexus, also called the Batson's plexus. This Batson's plexus is connected intrinsically to the basilar plexus, and this basilar venous plexus is connected to the dural venous sinuses. Okay, so prostatic carcinoma can reach your dural venous sinuses even, and so prostate cancer can metastasize to the brain. Okay, so it is very dangerous, and it can also travel to the heart and the lung. Okay, as connected to the heart. From the heart it can go via the pulmonary vessels to the lung. Talking about the lymphatic drainage, internal iliac lymph nodes, external iliac lymph nodes, and sacral lymph nodes. These are your lymphatic drainage of the prostate gland. Nerve supply sympathetic L1 to L2 and parasympathetic S2 to S4. Okay, S2, S3, S4. These are via the pelvic splanchnic nerves. What are the age-related changes? That is, at the childhood, the gland is very small and it is only made for fibromuscular stroma. At puberty, that the glandular part grows rapidly under testosterone influence. At the third decade of life, that is about 30 to 35 years of age, there are infoldings in the lumen of the prostatic follicles. The prostatic follicles, this are enfolded like this, okay. And in the fourth decade, in the 40 to 45 or 50, we have no changes. The fifth decade, more than 50 years, there is variable degree of prostatic hypertrophy. So prostate problems are common in people who are the males who are above the 50 years of age, okay. So this is fourth decade, there is variable degree of prostatic hypertrophy, okay. So that's all about the prostate gland. Let's move on to the next part. Okay, so let's discuss the course of your pelvic arteries. So pelvic artery is important. You know about the common iliac artery. Common iliac artery divides into your external iliac artery and the internal iliac artery. So basically we are discussing the internal iliac artery. So internal iliac artery will give a branch that will divide into anterior division and posterior division. So internal iliac artery divides into anterior and posterior divisions, okay. And this posterior division is basically turning back, okay, in this greater sciatic foramen, this lesser sciatic foramen, and it is giving your iliolumbar artery and your lateral sacral artery. It is giving your iliolumbar artery, okay, and two lateral sacral arteries, okay. And about the anterior division, this is the anterior division, okay. And this anterior division is giving branches, giving branches, that is a middle rectal artery, okay, inferior gluteal artery, and it is continuing downwards. So we have the middle rectal artery and your inferior gluteal artery, and other four branches that are your superior vesicular artery, obturator artery. In females you have the uterine artery, and in males you have the inferior vesicular artery, okay. In females, in the place of inferior vesicular artery, you have the vaginal artery, okay. So this and this inferior gluteal artery, this is the largest branch of anterior division of internal iliac artery, okay. So these are your pelvic arteries. Talking about the this anterior division gives another branch, that is your SVA, that is remnant of the proximal part of the umbilical artery, okay. So this SVA, this also gives a artery to the vas deferens and supplies the urinary bladder, okay. And the inferior vesicular artery, IVA, in males, okay, this gives branches to the ureter, okay, and to the prostate gland also. Inferior vesicular artery was one of the branches to the and that in the males, okay, it is innervating the prostate gland. We talked about the prostate gland a few minutes before, okay. And we have this medial umbilical ligaments, you know about all this, okay. And this inferior vesicular artery in males, it supplies the base of the bladder. It gives innervation to prostate gland, and it is also giving innervation to the terminal ureter and to the seminal vesicle, okay. And this SVA, that is your SVA is your superior vesicular artery, okay. This superior vesicular artery is the remnant of the proximal part of umbilical artery. So the SVA and these two parts, your medial umbilical ligaments, these are all your remnants of your umbilical artery, okay. And vaginal artery in female, this is supplying a vaginal wall, terminal ureter, and the base of the bladder, okay. As in males, the inferior vesicular artery is supplying the base of the bladder, so it also supplies the base of the bladder in females, okay. Prostate gland, so we don't have prostate gland in the female. And terminal ureter, okay. We don't have seminal vesicle also, so in place of seminal vesicle you have a vaginal wall, okay, for the vaginal artery, okay. And this inferior gluteal artery and this obturator artery, inferior gluteal artery and the obturator artery are parietal branches, and rest all are visceral branches, okay. So this obturator artery is one of the branches, that is your parietal branch, okay. And this inferior gluteal artery also, okay, inferior gluteal artery, we have the inferior gluteal artery, okay, which is a parietal branch, okay. And rest all are visceral branches. So this completes our pelvic arteries. Let's move on to the next part. So we have some embryological discussions to do, then we'll finish up the pelvis part, okay. So development of prostate gland, so it develops in the third month of intrauterine life. The endoderm of urogenital sinus, this gives rise to the glandular part, okay. The endoderm of urogenital sinus, okay, and this splanchnopubic lateral plate mesoderm, this will form your stroma of the prostate gland, okay. Splanchnopubic lateral plate mesoderm forms your stroma of the prostate gland. So you can include this development in your answer when you are writing the long question of a prostate gland, okay. That's all. Okay, so let's discuss the development of the urogenital system. So basically into your systemic embryology of the pelvis, that is we have the three mesodermal masses, okay, which is called as a nephrogenic cord. This whole part is called as a nephrogenic cord. So we have two nephrogenic cords, and the initial part is the pronephros, mesonephros, and then the metanephros. Okay, then you have the ureteric bud here, okay, this is called as the ureteric bud. Okay, and these two parts which are extending from the mesonephros and to going to the urogenital sinus. Okay, this is the urogenital sinus, which will form the endodermal urogenital sinus, which will form your future bladder. Okay, and this both are coming, which are called as mesonephric ducts or the Olffian ducts, and this is a trigone is also mesodermal. Okay, so talking about this, we have the metanephric duct. This metanephric duct is coming down. Okay, this metanephric duct is coming down, and this is a metanephros. Okay, so you have the metanephric duct. This whole part is a metanephric duct. It's called as a metanephric duct. Okay, and this metanephric duct is coming down and is forming a metanephric blastema. Okay, this metanephric blastema in future, okay, it will give rise to a secretory part of kidney, that is Bowman's capsule, PCT, loop of Henle, and the DCT. And this ureteric bud will give rise to a collecting part of the kidney, that is a collecting duct, renal papilla, calyces, renal pelvis, and the ureter. Okay, so ureteric bud and your metanephric duct, you know. Okay, and about the development of male urethra, so we have the urogenital sinus, that is endodermal in origin. Urogenital sinus is endodermal in origin. Okay, then have the ejaculatory ducts and the prostate gland and all, prostatic urethra. Okay, this is endodermal plus mesodermal. Okay, endodermal plus mesodermal. This membranous part, this is endodermal. Okay, and this whole part is endodermal. Spongy urethra is endodermal. Okay, and the terminal urethra and the glans penis, it is ectodermal. Just importantly remember this ectodermal part. Okay, so glans penis and the clitoris, these are ectodermal structures. Just importantly remember. In female urethra, we have this posterior wall and the anterior wall. Okay, so posterior wall is mesodermal and the anterior wall is endodermal. Okay, so talking about this, we have the same nephrogenic cord, okay, which is mesodermal, pronephros, mesonephros, metanephros. Okay, so the same ureteric bud will be coming. Okay, and we have another duct in female, that is a paramesonephric duct. This is a paramesonephric duct. Okay, and here the mesonephric duct is called the Olffian duct. Okay, here the mesonephric duct, there are the mesonephric duct, that is the same Olffian duct. Okay, so we will see two ducts, okay, which will just try to regress. Okay, and this paramesonephric duct is called the Mullerian duct. Okay, and about the this paramesonephric duct is there and mesonephric duct is there. Okay, and urogenital sinus, that is endodermal in origin, and trigone, which is mesodermal. Okay, so talking about this, we have a pouch here, which is formed here, which is called as the sinovaginal pouch. Okay, and this mesonephric duct, paramesonephric duct, is a Mullerian's duct. This Mullerian duct will give rise to your this part of fallopian tube, your fundus of the uterus. Okay, and all these parts of fallopian tube and the infundibular part. Okay, and from the urogenital sinus, this vaginal part is developed. Okay, so this is the embryology. Okay, talking about the mesonephric duct derivatives in male, the mesonephric duct derivatives, and in female, what are the mesonephric duct derivatives? Okay, so mesonephric duct in males will develop your trigone. Okay, your ureteric bud and all the derivatives of ureteric bud, your posterior wall of prostatic urethra, spermatic pathway, that is the vast difference is ejaculatory duct up to your seminal vesicles, and the appendix of the epididymis, this is called as the appendix of the epididymis. Okay, and in females, okay, the same trigone, the ureteric buds and the derivatives, posterior wall of urethra. Okay, and the Gartner's duct, that is also called as the duct of Euphoran. Okay, the duct of Euphoran, that's the Gartner's duct, is located between the broad ligaments. Okay, Gartner's duct in females. Okay, so and this spermatic pathway and appendix of epididymis, obviously we won't see in females. Okay, and the derivatives of paramesonephric duct, so we have in males the appendix of the testis, your prostatic utricle. Here we saw the prostatic utricle in your when we are discussing male urethra, it is a blind diverticulum which represents the vagina in female, so it is called the male vagina. Okay, what is the male vagina? You have the prostatic utricle, and in females you have the fallopian tube, you have the uterus, and the upper part of the vagina, that is developed from the paramesonephric duct. You can see from here. Okay, you have the uterus and the fallopian tube and the upper part of the vagina. Okay, this is developed from the paramesonephric duct. Okay, and this whole part is developed from the urogenital sinuses. Okay, urogenital sinus. So this completes your urogenital system development. Okay, and now we are gonna finish the chapter. Okay, the chapter is now done. Okay, so let's meet in any other chapter then. Let's talk about a few clinicals which you might have left. So what is vasectomy? Vasectomy is a simple surgical procedure done for family welfare. Okay, a segment of vas deferens is exposed from a small incision. Okay, and the two ends are tied and a small piece of vas deferens is removed. Okay, small piece of vas deferens is removed. This is done on both sides. So it is this vasectomy. This vasectomy method is basically a family contraceptive measure. Okay, a contraceptive measure. Okay, in which the both ends of vas deferens are like cauterized. These are cauterized or tied by some thread. Okay, so hormones continue to be produced and the person remains potent. Since the sperm cannot pass in the distal part of vas deferens and ejaculatory duct, the person becomes sterile after 3 to 4 months. Okay, the person can ejaculate, the person can release the sperm outside. Okay, release the semen outside, but there will be no sperms. There will be no sperms in the semen. Okay. What is hydrocele? We talked about the hydrocele. Remember, hydrocele is that the testis invaginates. Okay, the processus vaginally. So there's visceral layer and parietal layer of peritoneum. Okay, due to the collection of excess fluid in between the two layers, the hydrocele will be formed. After that, we have picture is given or what? I don't know. Picture is not given. No problem. Then we talked about the cryptorchidism also. Cryptorchidism is the undescended testis. Okay. So the testes do not come down to the scrotum at the birth, or soon after. Okay, these are hidden testes. Okay, and the path have been deviated. Okay, so the testes may be undescended and maybe in your lumbar region. Okay, or your iliac fossa, or your inguinal canal, or your superficial inguinal ring, or at the upper end of the scrotum. And so this phenomenon is called the ectopic testis. Okay, ectopic testis. And what is varicocele? Varicocele, I told, is a dilution tortuosity of the pampiniform plexus in the spermatic cord. This is called as varicocele, and it occurs most commonly in the left side, most commonly on the left side. Factors are left testis hangs more commonly. Why it occurs more commonly on the left side? It can be asked because left testis hangs a little lower than the right. Okay, and the left testicular vein drains to left renal vein at right angle. Okay, so you have a right angle in which it is draining. Okay, in which it is draining. Okay, a right angle drains at a right angle, and loaded pelvic colon may press upon the left testicular vein and prevents its proper drainage. Okay, and varicocele may lead to your infertility. Understood? Remember, we talked about the ischioanal fossa, fossa, that is ischiorectal fossa. Okay, so you can have ischioanal abscess. It is common as ischioanal fossa are situated on the two sides of the anal canal deep to the skin of the perineum. Okay, so it is less painful as compared to your perineal abscess. Because perineal space is situated in ischial tuberosity and subcutaneous part of sphincter urinae externus. Okay, as the septa in this space is very small and fat is tightly disposed, infections are very painful in the perianal abscess. Okay, but ischioanal abscess, it is less painful. Okay, so this is the fact. And this pudendal nerve block, we do a pudendal nerve block, and the site of this nerve is blocked by anesthetic drug as it lies on the ischial spine. Blockage can be done through the vagina or through the perineum. Okay, it is called the pudendal nerve block, and it is a anesthetic procedure during a vaginal deliveries or forceps delivery. Okay, so we do a pudendal nerve block. Understood? Yes. So basically we talked about all the clinicals. Okay, and we have talked about the prolapse of the uterus. Okay, and what is tubal pregnancy? Tubal pregnancy is sometimes the fertilized ovum, instead of reaching the uterus, adheres to the wall of uterine tube and starts developing there. Okay, the fertilized ovum doesn't reach the uterus but starts developing in the fallopian tube. Okay, let's say if this is a fallopian tube, okay, and this is a uterus. So the fertilized ovum must reach the endometrium and be implanted there, but it doesn't implant here. It implants here and starts developing here. Okay, and this is known as tubal pregnancy. And the enlarging embryo, okay, mostly leads to rupture. This, when it gets enlarged, it ruptures your fallopian tube. Okay, What is tubectomy? Tubectomy, as we had a vasectomy in your males, we have tubectomy in your females. It's a simple operative procedure for females for family welfare. The peritoneal cavity has to be opened, and fallopian tube is ligated. Fallopian tube is ligated at two places, and the segments are removed. Okay, this may be cauterized or this may be burnt, and so. Okay, hysterectomy is the removal of your uterus. Hysterectomy is removing uterus for various reasons. It's called a hysterectomy. Okay, and integrity of ureter has to be maintained, so as to prevent any damage to the ureter. Okay, ureteric colic. What is ureteric colic? It's referred to the T11 to T12 segment. Colic means a sharp excruciating pain is called as a colic. Colic means a sharp excruciating pain. Okay, colic is a sharp excruciating pain. Pains radiates from the loin to the groin. Okay, it radiates to the groin region. Understood? This is your ureteric colic. Common diseases of kidney are nephritis, pyelonephritis, tuberculosis of the kidney, TB kidney is also a fact, renal stones and the tumors. Okay, and common manifestations are your renal edema and hypertension will occur, and transplantation can be tried, or you can have lithotripsy. Okay, like shockwave lithotripsy is used for the removal of stones. Okay, shockwave lithotripsy. Okay, shock waves are given and the stones are dissolved due to jerk or shock waves. Okay, and then intrauterine contraceptive devices. Okay, this is the basic principle underlying for the use of various intrauterine contraceptive devices. Okay, what is the basic principle? That insertion of a foreign body is inserted into the uterus, which can prevent implantation of the fertilized ovum. Okay, like your copper T, this copper T, and your multi-load. Okay, copper T, multi-load, these all are IUDs. Okay, IOCDs or IUDs. Okay, which can be like used as a contraceptive devices. Okay, understood? So this completes all your clinicals from the BDC itself. Okay, and we finished this chapter, that is your pelvis. Okay, we finished the pelvis, and it has been 2 hours and 10 minutes of video lecture, which we revised the chapter. Of course, the chapter is a small chapter, but we revised it in detail. We talked about all the things which are needed for exams and all. Okay, so that's all. Let's meet in any other video. Okay, thank you.